Right. So what is that I'll be discussing in the endocrinology quick revision. Now, before starting the session, let me tell you the PDF of all these particular 4 parts will be shared to you on Dr. Banu Prakash Telegram channel. Okay. So even the today's PPTs, that is endocrinology and as well as cardiology, have already been shared on Dr. Banu Prakash Telegram channel. Not only that, even on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Guba, I have shared these PPTs. So even after the completion of the session, I'll be sharing you the PPTs with annotations, right? So you just sit down and relax. Okay, you need not write much, right? Don't worry about like whether we need to write or not. Don't worry about that. So immediately after the session is over, I'll be sharing you this with annotations wherein you can do a quick recap just before the exams. Okay. So having said this, now let us start with the session. So now what is that I'll be covering in this endocrinology? So in endocrinology, I'll be covering all these particular topics, like the topics like pituitary disorders, that is acromegaly, pituitary tumors, prolactinoma, craniopharyngioma, and hypopituitarism, diabetes insipidus, and SAADH. These are all your pituitary disorders. Then next is the adrenal gland disorders, that is Cushing syndrome, Conn's syndrome, Addison's, and then pheochromocytoma. Then we have thyroid disorders, that is hyper and as well as the hypoparathyroidism. Then thyroid disorders, that is hyper and hypothyroidism. Then pancreatic disorders like diabetes mellitus, then glucagonoma. Next, carcinoid tumors or carcinoid syndrome, MEN syndromes. All these particular topics, I'll be doing a quick revision in this particular endocrinology quick revision. And along with all these, the two important things which I have added in this session is I'll be doing the quick revision of the image-based questions of each and every topic, and as well as I'll be discussing some of the previous year questions related to the endocrinology, cardiology, neurology, nephrology, whatever the chapter which I'll be discussing. Okay, right. So having said this, now let us start with this session. Okay, so what did I tell you? I'll be also discussing the previous year questions along with the discussion of the topic. Now, if you see the first important clinical scenario which has been asked recently, that is 49-year-old man presents with history of difficulty in having the sleep or history of difficulty sleeping. He reports feeling increasingly tired and the generalized weakness which he attributes his poor sleep pattern. Additionally, the patient has noticed that he has gained weight and sweats very easily. On examination, the patient has coarse facial features. What is the most likely diagnosis in this clinical scenario? The options are hyperthyroidism, Cushing syndrome, acromegaly, hypothyroidism, diabetes mellitus. So what do you think is this clinical scenario suggestive of? So if you take this clinical scenario where the individual is having coarse facial features, profusely sweating, gaining of the weight, poor sleep pattern, all these points are suggestive of the acromegaly. Now we will try to rule out the other options. You take the hyperthyroidism. What is that these individuals will have? In these patients with hyperthyroidism, they will have weight loss, they will not have weight gain. Then in Cushing syndrome, they will have weight gain, but they don't have that sweaty skin. That hyperhidrosis will not be there in patients with the Cushing syndrome. So Cushing syndrome is ruled out. Then what about in hypothyroidism? In hypothyroidism, they'll have weight gain, but how will be the skin in these individuals? There will be a dry skin. Now, in patients with diabetes mellitus, the classical presentation will be that polyuria, polydipsia, polyphagia. That is very common in type 1 diabetes mellitus. But whereas in type 2 diabetes mellitus, the presentation will be in the form of increased fatigability, repeated infections. That will be the presentation in case of the diabetes mellitus. So the correct answer here will be the acromegaly, right? Now we will discuss about the acromegaly. So this is a very important image that will be asked related to the acromegaly. So if you take the facial features in these individuals, how are these facial features? So coarse facial features, and if you observe clearly, you take the frontal bossing will be there. And how will be the nose in these individuals? They'll have broad nose and they will have the protrusion of the mouth, and that we call it as the prognathism. Now this will be the facial features in patients with the acromegaly. Then how will be the extremities in patients with the acromegaly? See, this is the extremity in patients who is having acromegaly, where they'll have broad hands and as well as swollen fingers, and that is the reason why even the ring size in these individuals will be increased. And how will be the foot in patients with the acromegaly? They'll have a broad foot, right? And thereby the shoe size is increased in patients with the acromegaly. And these are the extremities within the normal individual. So this is just a comparison from acromegaly, right? Now, after having discussed about like the external picture, now let me just show you all the clinical features. Now, so this is a table which shows you all the features of the acromegaly. What will be that? That includes the local tumor effect, right? That includes the local tumor effect. What is the most common cause of acromegaly? The most common cause of acromegaly is somatotroph type of pituitary adenoma. Now it's a tumor, so that is the reason why you will have the local central effects. That means they will be having, the individual will be having very severe headache, and this tumor can be causing the compression of the surrounding structures like optic chiasma, and that is the reason why the individual will also have the visual field abnormalities. Somatic manifestations, just now we have discussed. What is that? They will have enlarged hands and as well as the enlarged foot. Now, musculoskeletal manifestations, that will be in the form of arthralgia and nerve compression syndromes. That is very, very important. What is that nerve compression syndromes in these individuals? That includes carpal tunnel syndrome, where there will be compression of the median nerve. That is very, very important that you need to know. Now, these patients, they'll have sleep disturbances. Why is that these individuals will have sleep disturbances? Is because the tongue of these individuals is swollen. So whenever the individual sleeps, there is a very high chance that the swollen tongue may fall back, and thereby the patient will have difficulty in sleeping during the night, and that we define it as the obstructive sleep apnea, where intermittently the individual has to get up for breathlessness. Then skin manifestations. Let me tell you, all the organs, they are enlarged, including the skin. So there will be the hypertrophy of the skin. Skin thickness increases. So whenever the skin thickness increases, the sweat glands within the skin becomes hyperplastic. And once there is hyperplasia of the sweat glands, there will be profuse sweating. That is what you will have in patients with the acromegaly. Next is colonic manifestations. What did I tell you? All the organs, they get enlarged in size, or they will have the excessive proliferation, because of which there will be gastrointestinal polyps. And next important thing is the cardiovascular manifestations. The cardiovascular manifestations, that includes the left ventricular hypertrophy, hypertension, and finally, what is the cause of death in patients with the acromegaly is the congestive cardiac failure. That would be the cause of death in patients with the acromegaly. And what did I tell you? All the visceral organs, they get enlarged in size. There will be splenomegaly, there will be renomegaly, there will be hepatomegaly, there will be cardiomegaly, there will be increase in the size of the lungs. So visceral organ manifestations will be there. Now the sexual functions, if you take, now the etiology, what did I tell you? Somatotroph type of pituitary adenoma. That means the tumor which is originating from somatotrophs. But in some patients, there can be mammosomatotroph type of pituitary adenoma. What do you understand by the word mammosomatotroph? That means the tumor containing somatotrophs which will be producing excess amount of growth hormone, and the tumor contains lactotrophs which will produce the prolactin. So mammosomatotroph type of pituitary adenomas, they will have the sexual abnormalities, and that will be in the form of menstrual abnormalities, that is amenorrhea, and they will also have galacturia and decreased libido. Why? Because prolactin will decrease the testosterone production, and that is the reason why there will be decreased libido. Now, carbohydrate intolerance will be there in patients with acromegaly. Why? Because growth hormone will increase the hepatic gluconeogenesis, and that is the reason why in patients with acromegaly there will be carbohydrate or the glucose intolerance. Then followed by that, what exactly is the cause of death in patients with the acromegaly? That will be the cardiac failure. That is the cause of death. Then how do you investigate these patients with the acromegaly? Now, if you see the question, what is the best initial investigation? That is IGF-1 levels. These IGF-1 levels are elevated. What is your IGF-1? Which is nothing but somatomedin. Now, the growth hormone which is produced in anterior pituitary will come and act on the liver. Liver is the target organ for the growth hormone. So once the growth hormone acts on the liver, liver will be producing the IGF-1, and it is your IGF-1 or somatomedin that will be acting on the end organs for showing the physiological action of the growth hormone. So what will happen to your IGF-1 levels? That will be elevated, and that is the first line investigation in patients with the acromegaly. Then, what is a confirmatory test in patients with acromegaly? That is growth hormone suppression test. What is that? See, whenever you give glucose in a normal individual, the growth hormone level reduces. But in these individuals, there will be failure of growth hormone suppression in spite of the glucose load. That is what is called as the growth hormone suppression test, and that will be the confirmatory test. And another very, very important investigation is the radiological imaging of the digits. So when you do a radiological imaging of the digits, you will observe the isolated spade-shaped phalanx. That is a classical radiological imaging in patients with the acromegaly. And not only that, when you take the lateral view of the X-ray of the foot, right? When you take the lateral view of the X-ray of the foot, what is that you will notice is, you will notice that the heel pad thickness is increased. How much is the normal heel pad thickness? Normal heel pad thickness is 13 to 21, but in patients with acromegaly, that will be more than 21, right? So these are the investigations. Then how do you treat these patients with acromegaly is another very, very important, the previous year question. Now, you see this question. A 19-year-old woman presents with concerns about changes in her facial appearance, right? And in particular, her nose and jaw seem quite large. She is also quite sweaty, and despite using antidepressants, is finding it difficult to control and is afraid of embarrassment at the university. A glucose tolerance test is performed and found to be raised. The most appropriate management in this patient will be. So, diagnosis, what exactly is the diagnosis? Diagnosis is acromegaly. So, what are the points to tell that this patient is having acromegaly? Enlarged nose, enlarged jaw, and the patient is quite sweaty. These are all the, and glucose tolerance test is performed and it is found to be raised. All these points tell you that the patient is having acromegaly. Now, what is the treatment of choice in acromegaly? Right, the treatment of choice in acromegaly is the transsphenoidal surgery. Right, it is transsphenoidal surgery. That is a first line treatment in patients with the acromegaly. Right, that will be the first line treatment in patients with the acromegaly. That is transsphenoidal surgery. That is a treatment of choice. Now, what about the other options? Let me tell you, those individuals who are not prepared for surgery, or where the surgery is contraindicated because of the risk factors, in them we give medical management. In the medical management, what is the drug of choice? The drug of choice will be the somatostatin analog, that is the octreotide. Now you take pegvisomant. Pegvisomant, it is a second line agent. Pegvisomant is a second line agent. Then what about bromocrypton? See, whenever the patient is having acromegaly secondary to mammosomatotrough type of pituitary adenoma, then we give this bromocrypton, right? And we have one more drug in case of persistent severe form of acromegaly. So, in persistent severe form of acromegaly, the drug that you will be giving is Reloxifen, right? What is Reloxifen? It is a selective estrogen receptor modulator. Now, in what way, what is the mechanism of action of Reloxifen in case of acromegaly is that, remember, Reloxifen will not normalize the growth hormone level. Reloxifen will normalize the serum IGF-1 levels, right? Will normalize the serum IGF-1 level. What is serum IGF-1? It is the one which is produced from the liver in response to your growth hormone. So, your Reloxifen will normalize the serum IGF-1 levels but not the growth hormone levels. Okay. So, that is about your acromegaly story. Now, one quick question on the growth hormone. Can anyone tell me Laron dwarfism is due to growth hormone deficiency, GNR, growth hormone releasing hormone deficiency, growth hormone receptor resistance, IGF-1 deficiency? What exactly you mean by this word? Laron dwarfism. Yes. So, Laron dwarfism, it is nothing but the growth hormone receptor resistance. Growth hormone receptor resistance. Okay. Right. So that is about your Laron dwarfism. Now, after having discussed about the acromegaly, we will move on to the next. Okay. You answer this question. A patient was prescribed bromocrypton for prolactinoma and responded to her symptoms. What is its mechanism of action? D2 receptor partial agonist increases the prolactin level, normalizes the serum prolactin level, D2 receptor antagonist. Now, if you take this bromocrypton, so bromocrypton is the one which is used in the treatment of prolactinoma, and this particular bromocrypton, it is not a D2 receptor partial agonist. It is a D2 receptor complete agonist, and this bromocrypton will normalize the serum prolactin levels. The bromocrypton will normalize the serum prolactin levels. Okay. Now, let me discuss at this point about the pituitary tumor, that is prolactinoma. Now, if the question is being asked here, like, which is the most common tumor of the pituitary? Which is the most common tumor of the pituitary? Non-functioning adenoma, prolactinoma, ACTH producing adenoma, then oncocytoma. What do you think is the most common tumor of the pituitary? Any one of you? The most common tumor of the pituitary, it is not prolactinoma. It is not prolactinoma. Remember, if you have an option like non-functioning adenoma, that is the most common tumor of the pituitary. Please remember, this is a very, very important point. Now, when will the prolactinoma be the answer? If the question is asked, what is the most common secretory tumor? Right? If the question is asked, what is the most common secretory tumor? If the question is asked, what is the most common secretory tumor, then the answer will be the prolactinoma, right? But if there is no mention, then you should answer it as non-functioning adenoma. That is the most common tumor, right? That is the most common tumor of the pituitary, okay? Right. Now, having said about this, we'll move on to the next question, right? Which is the most common cell involved in non-functioning pituitary adenoma? Which is the most common cell involved in non-functioning pituitary adenoma? The options are gonadotrophin producing cell, prolactin producing cell, growth hormone producing cell, TSH producing cell. What is the most common cell involved in non-functioning pituitary adenoma? Right. Then the answer here will be very good. So that will be the gonadotrophin producing cell. Right. Yes, Meet Patel. So if the question is asked non-functioning, if the point is there like non-functioning, then go with the non-functioning. Now, what is your question, Meet Patel? If they ask what is the most common functional tumor, if they ask what is the most common functional tumor, then the answer I have already said you previously, that will be prolactinoma, right? That will be prolactinoma. Okay, right. Now, let me just quickly recap in toto about your pituitary tumors, right? So, you see this question. Ramkali Bai, a 35-year-old male, presented with 1 year history of menstrual irregularity and galacturia. She also has on and off headache. Her examination revealed bitemporal superior quadrant anopia. Her fundus examination showed primary optic atrophy. Which of the following is the most likely diagnosis in this case? Craniopharyngioma, pituitary macroadenoma, ophthalmic aneurysm, and chiasmal glioma. So, what do you think is the correct answer in this question? So, the correct answer in this question is the pituitary macroadenoma, and it is not craniopharyngioma. Now, let me discuss about the pituitary tumors. So, these pituitary tumors, they are being classified into two types depending upon their size. So, microadenoma means the size of the tumor will be less than 10 mm. Macroadenoma means the size of the tumor will be more than 10 mm. Now, what will be the difference in the clinically is both of them, they will have the manifestations, both of them, they will have the endocrine manifestations. Like for example, you take prolactinoma. What will be the endocrine manifestations of prolactinoma? The endocrine manifestations of prolactinoma in case of males, the individual will have decreased libido and there will be decreased fertility. That is what you will have in males. Whereas in females, like what will be the endocrine manifestations, whether it is micro or macroadenoma, same. They will have decreased fertility, right? They will have amenorrhea, then followed by that they will have galacturia. So these will be the endocrine manifestations in prolactinoma in both micro and as well as macroadenoma. But in macroadenoma, what will be the manifestations that will be there additionally? Additional manifestations in macroadenoma will be the pressure effects on the surrounding structures. What will be that pressure effect on the surrounding structures? Like you see here. In case of the macroadenoma of prolactinoma, the tumor will be compressing the central part of the optic chiasma. So when tumor is compressing the central part of the optic chiasma, the central part of the optic chiasma, they bring the vision from the temporal areas. So that is the reason why the individual will have what is called bitemporal hemianopia. And along with that, in case of macroadenoma, because the tumor size is more, the individual will have a headache and they can also have optic atrophy. That is because of raised intracranial pressure. Now, what will be the close differential diagnosis? Right. What will be the close differential diagnosis for your prolactinoma? The close differential diagnosis for prolactinoma will be the craniopharyngioma. Even in craniopharyngioma, you will have the features of the hyperprolactinemia. Right? Even in craniopharyngioma, you will have the features of hyperprolactinemia. And what exactly is your craniopharyngioma? It's a tumor which is originating from rat case pouch. And this craniopharyngioma will compress the hypothalamo-hypopituitary tract. Now, when it is compressing this infundibulum or hypothalamo-hypopituitary tract, what happens is the dopamine which is coming from hypothalamus will not act on the anterior pituitary. When dopamine which is coming from hypothalamus does not act on anterior pituitary will be producing excess amount of prolactin. That is the reason why in craniopharyngioma you will have hyperprolactinemia features. Now, along with that, this craniopharyngioma will also cause the mass effect. That is, it will cause the compression on the optic chiasma. But here the manifestation will be in the form of bitemporal inferior quadrantanopia. Right? It will be bitemporal inferior quadrantanopia. Whereas in case of prolactinoma, it is bitemporal superior quadrantanopia. But whereas here it is bitemporal inferior quadrantanopia. That is what you will have in patients with the craniopharyngioma. Now, let me just quickly tell you what is the investigation of choice. Investigation of choice of hyperprolactinemia is thyroid releasing hormone estimation, luteinizing hormone estimation, prolactin estimation, then estradiol estimation. What exactly is that? That will be prolactin estimation. And this prolactin estimation should be done early in the morning, that too in a fasting state. Right? That too in a fasting state. Okay? Because any amount of stress can increase the prolactin levels. So that is the reason why early in the morning in the fasting state, the prolactin level should be done. Now, what should be the prolactin level to call it as prolactinoma? Remember, if the levels are more than 200 nanograms per ml, then we call it as the prolactinoma. And if the levels are in between 100 to 200, it is strongly suggestive of prolactinoma. And if the levels are less than 100, let me tell you, it might be due to any cause except prolactinoma. What are the other causes of hyperprolactinemia? You have some physiological causes. Like, what are the physiological causes? Like sleep, stress, pregnancy, then lactation. These are the physiological causes. Then what are the pathological causes for hyperprolactinemia? Pathological causes, they include the tumors like prolactinoma and craniopharyngioma. Systemic conditions like chronic renal failure and as well as cirrhosis of liver and primary hypothyroidism. There are certain drugs which will cause the hyperprolactinemia like cimetidine, methyl-dopa, metoclopramide, then phenothiazines. These are all the drugs which can cause the hyperprolactinemia. Now, how do you treat these patients with hyperprolactinemia? So, whether it is microadenoma or macroadenoma, whatever it might be, the first line treatment, right? The first line treatment will be medical management. It is not like acromegaly. In case of acromegaly, the first line treatment is the pituitary resection. But here, the first line management will be the medical management. And what will be the drug of choice here? The drug of choice will be cabergoline, right? Whereas in pregnancy with prolactinoma, what will be the drug of choice? That will be your bromocrypton. That will be bromocrypton. Now, in case of microadenoma, what should be your target levels of your prolactin levels? Less than 20. If it is being maintained less than 20 with your bromocrypton or cabergoline, then continue the same treatment. But in spite of giving cabergoline or bromocrypton, if the prolactin levels are still high, like more than 50, then you need to consider for surgery. Whereas you take for macroadenoma, like you need to start with the dopamine agonist, that is bromocrypton or cabergoline, and every 4 months you need to repeat the MRI. And in the repeat MRI, for suppose if the tumor size is reducing, then continue the same treatment. But if the tumor size is same and the prolactin levels are still high, then you need to consider for surgery in case of the prolactinoma, right? So this is about like how you will manage a case of the prolactinoma. Now, so this is a quick revision of the prolactinoma. Now, we'll move on to the next topic, right? So, what is the next topic? That is the hypopituitarism. Now, what exactly you understand by this word hypopituitarism? That is where the individual is having partial or complete loss of the anterior pituitary function. Now the very important question that will be asked is, what is the hormone that is being reduced early? The hormone that is being reduced early will be the growth hormone, right? That will be the growth hormone. Followed by that, the next hormone that will be reduced is gonadotrophins, that is follicle stimulating hormone, and as well as the luteinizing hormone. And what is the important etiology that will be causing your hypopituitarism? There are multiple etiologies, but the most common cause for your hypopituitarism will be pituitary adenoma. That will be the most common cause for your hypopituitarism. Then followed by that, right, what is the management in patients with the hypopituitarism? So let me tell you, in patients with hypopituitarism, the hormone, even though the one which is lost early is growth hormone, the one that you should supplement first will be cortisol, because the survival of the individual cannot be expected without cortisol, right? Cortisol is a life-saving hormone, right? So cortisol is the hormone that should be supplemented first in patients with the hypopituitarism. So that is in toto about your hypopituitarism, right? Now, once we are done with this topic of the hypopituitarism, the other important pituitary disorders are like diabetes insipidus and syndrome of inappropriate antidiuretic hormone. Now, what is this diabetes insipidus? It is a clinical scenario where there is decrease in your antidiuretic hormone or there is resistance to the antidiuretic hormone. That is what is your diabetes insipidus. Now, what is a characteristic feature? Because of decrease in antidiuretic hormone or resistance to the action of antidiuretic hormone, the water absorption at the level of the collecting duct does not occur, and thereby the individual will be producing abnormally large volumes of dilute urine. And how much will be that large volumes? That is 24-hour urine volume exceeds more than 40 to 50 ml per kg body weight, or if you take per 24 hours, it is more than 3000 ml per 24 hours. Okay, so this is according to your kg body weight per hour, right? So this is like more than 3000 ml per 24 hours. And in these individuals with diabetes insipidus, like what exactly will be the abnormality in the plasma and as well as the urine osmolality? So like this is the previous year question. This is a PYQ on diabetes insipidus, right? What did I tell you in this quick revision? I'll be discussing the PYQs, I'll be discussing the image based questions, I'll be discussing the individual topics with the quick revision of the individual topics. Okay. Right. Now choose the best lab value for a patient with central diabetes insipidus. On left hand side you have urine osmolality and on right hand side you have the serum osmolality. Now in patients with diabetes insipidus, what is that we know? We know that the urine osmolality will be reduced. And what will happen to serum osmolality? The serum osmolality will be increased. That is what you will have in patients with the diabetes insipidus. Now what is the correct option with the explanation here? That will be your first option. So urine, how much is the normal urine osmolality? Normal urine osmolality will be 300 to 1000 milliosmoles. And how much is the normal serum osmolality? That will be 285 to 295 milliosmoles. That is the normal serum osmolality. So the correct answer here will be 50 to 300, 50 bar 300, because like the serum osmolality should be increased more than 295. Urine osmolality should be decreased. That should be less than 300, right? So the correct answer is A here. Now, what exactly are the etiologies that will be causing diabetes insipidus? What do you understand by the word central diabetes insipidus? It is a scenario where there is decrease in your antidiuretic hormone. Now, what do you understand by the word nephrogenic diabetes insipidus? It is the one where there is ADH receptor resistance. Now, the important etiology that will be causing central diabetes insipidus will be the head trauma. That will be the important etiology. Whereas in nephrogenic diabetes insipidus, mainly we have drugs. What are those drugs? These drugs include lithium. Then the other important drugs are the amphotericin B. The other important drugs are demiclocycline. Then we have methoxyflurane. Right, we have methoxyflurane. So these are the drugs which can cause the nephrogenic diabetes insipidus. And we have metabolic conditions which can cause nephrogenic diabetes insipidus. That is because of the hypercalcemia and as well as the hypercalciuria. Even that can also cause nephrogenic diabetes insipidus. But one of the very important question that can be asked regarding the genetics of your nephrogenic diabetes insipidus is, that is the Wolfram syndrome. Now what exactly is your Wolfram syndrome? It is mainly due to mutation of this particular gene, that is WFS1 gene. And what is the mode of inheritance of this Wolfram syndrome? That is autosomal recessive type of inheritance. Now the another name of the Wolfram syndrome is, it is also called Didmore syndrome. Why is it called Didmore syndrome? DI stands for diabetes insipidus. DM stands for diabetes mellitus. OA stands for optic atrophy. D stands for deafness. So that is what is your Wolfram syndrome or your Didmore syndrome, which is a genetic disorder which will be causing your nephrogenic diabetes insipidus. Okay. Now, how do you work up this diabetes insipidus? Let me just show you a question. Okay, you see this. A 29-year-old man presents with 4-week history of polyuria and extreme thirst. The patient denies difficulty in voiding, hesitancy or hematuria, although the urine is very dilute. The patient does not believe he has lost any weight and maintains a good diet. No findings are found on urine dipstick. Right? The most appropriate investigation is serum osmolality, fasting plasma glucose, urine electrolytes, MRI scan of the head, water deprivation test. So what do you think is the correct answer in this question? So now if you clearly observe here, what all he says, polyuria is there and polydipsia is there. There is no polyphagia, right? There is no polyphagia, and urine dipstick is also normal. Urine dipstick is also normal. So like what will be this suggestive of? This will be suggestive of your diabetes insipidus. Actually, there are many other conditions which will be causing your polyuria. Apart from diabetes mellitus, the other conditions which will be causing polyuria is diabetes insipidus, psychogenic polydipsia, Conn syndrome, diuretic abuse, right? Diuretic abuse. So these and your hypercalcemia. These are all the conditions which can cause polyuria. But what did he say here? The appropriate investigation. And the other important point is, apart from polyuria and polydipsia, he doesn't have any other features of the conditions what I have discussed which will be causing polyuria. So that is the reason why we need to consider diabetes insipidus. Like for example, you take Conn syndrome. In Conn syndrome, apart from polyuria, what will be the other features? In Conn syndrome, they will have diastolic hypertension. They'll have severe muscle weakness. They'll have metabolic alkalosis. All that is not there. So your Conn syndrome and all we need not consider in this patient, right? So in case of diabetes insipidus, what do you think is the investigation of choice? That is water deprivation test. Now, what is the importance of this water deprivation test is, this water deprivation test, it is useful for differentiating diabetes insipidus from psychogenic polydipsia, right? It is useful for differentiating diabetes insipidus from psychogenic polydipsia, because even in psychogenic polydipsia, the patient will be having polyuria and as well as the polydipsia. Now, how can you rule out this? All that we will be discussing subsequently. But remember, in case of the diabetes insipidus, the investigation of choice is water deprivation test, right? Now, you see another important clinical scenario, that is a 33-year-old lady presents with polyuria and as well as polydipsia. Her symptoms started soon after a road traffic accident 6 months ago. The blood pressure 120/80, no postural drop. How much is the daily urine output? 6 to 8 liters is the daily urine output. And investigation revealed sodium 130, potassium 3.5, urea 15 milligrams per deciliter, sugar 65 milligrams per deciliter. Plasma osmolality 268, urine osmolality 45. What do you think is the most likely diagnosis in this clinical scenario? So the options are central diabetes insipidus, nephrogenic diabetes insipidus, acute tubular necrosis, psychogenic polydipsia. The answer in this question is the psychogenic polydipsia. It is not your diabetes insipidus at all. Why? Because in psychogenic polydipsia, the individual has some psychological disorder due to which he or she is consuming excess amount of water. So thereby, what will happen to serum osmolality in patients with psychogenic polydipsia? Decreases. Once serum osmolality is decreased, ADH is not produced. Once ADH is not produced, the water absorption at the level of collecting duct does not occur. So thereby, there will be decrease in the urine osmolality as well. So in psychogenic polydipsia, you will have both of them being reduced. Plasma osmolality reduced and urine osmolality is also being reduced. Whereas in diabetes insipidus, what is that you will observe? In diabetes insipidus, the serum osmolality is increased and urine osmolality will be decreased. That is what you will have in diabetes insipidus. Okay. So the correct answer here will be the D, that is psychogenic polydipsia. Now, what do you think is the drug of choice for central diabetes insipidus? This is one of the PYQ. So the drug of choice will be the desmopressin. And this desmopressin, it can be administered subcutaneously, it can be administered intravenously, it can be administered through inhalational route as well. Now, there are certain drugs which can enhance the action of your antidiuretic hormone. What are those drugs which can enhance the action of your antidiuretic hormone? That includes your chlorpropamide, which is your first generation sulfonylurea. then carbamazepine, that is the drug of choice for the focal epilepsy, and clofibrate. These are the three drugs which can enhance the action of the antidiuretic hormone. So along with this desmopressin, you can give any of these drugs which can enhance the action of the antidiuretic hormone. Okay, right. Now, what is the drug of choice for nephrogenic diabetes insipidus? For nephrogenic diabetes insipidus, the drug of choice will be the hydrochlorothiazide, right? So this hydrochlorothiazide will have paradoxical action in patients with the nephrogenic diabetes insipidus. What is that paradoxical action? This hydrochlorothiazide will increase the water reabsorption at the level of proximal convoluted tubule, right, in nephrogenic diabetes insipidus, right? And one more question that can be asked is, in lithium induced diabetes insipidus, the drug of choice will be amiloride, right? The drug of choice will be the amiloride. So this is about the story related to diabetes insipidus. Now, exactly contrary to that, we'll discuss about the SAIDH. What was diabetes insipidus? Where there is decrease in your antidiuretic hormone or antidiuretic hormone resistance is there. But in SAIDH, there is increased antidiuretic hormone levels. Now, SAIDH is associated with which type of bronchogenic carcinoma? Right. So if you take this SAIDH is the one is associated with oat cell carcinoma, which is also called small cell carcinoma of the lung. Now, if you take the features of the syndrome of inappropriate antidiuretic hormone, so all are true regarding SAIDH except increased levels of ADH, urine being hypoosmolar, the hyponatremia will be there, adequate hydration status will be there. So what do you think is the incorrect statement? Please remember, in patients with syndrome of inappropriate antidiuretic hormone, the urine will not be hypoosmolar, urine will be hyperosmolar. And why is all that? I'll discuss. Now, in patients with SAIDH, what is happening? There is increased ADH production. So because of which there is increased water reabsorption, right? Because of which there is increased water reabsorption. So because of that, there will be compensatory mechanisms that will be activated. What are the compensatory mechanisms? Once there is excessive water reabsorption, the fluid volume increases, so renal perfusion increases. Once renal perfusion increases, the RAS will get inhibited. And once the fluid level increases, the venous return to the right atrium increases. Once the venous return to the right atrium increases, there will be stretching of the right atrium. Once your right atrium is being stretched, there will be release of the atrial natriuretic peptide in excess quantities, right? And the third important is, because of excessive water reabsorption, the fluid level increases, blood pressure increases. That will stimulate the baroreceptors, in the sense they will give information to baroreceptors saying that the blood pressure is very high. So what these baroreceptors will do? Baroreceptors will inhibit the vasomotor center, and thereby there will be inhibition of your sympathetic outflow. So now, because of these compensatory mechanisms, what will happen to the serum sodium levels? Decreases, because once RAS is inhibited, aldosterone is not formed. Once aldosterone is not formed, so sodium absorption does not occur. The sodium is kicked out. And atrial natriuretic peptide will cause natriuresis, so sodium is also being kicked out, so that will result in hyponatremia. So if you take the clinical features of SAIDH, all these clinical features are mainly because of the hyponatremia. What will be that? Projectile vomiting, seizures, headache, altered sensorium, coma, and finally death of the individual. Then what is the investigation of choice in patients with the SAIDH? Investigation of choice in patients with SAIDH will be the water loading test. See, in patients with diabetes insipidus, the investigation of choice is water deprivation test, but whereas here it is a water loading test. Okay, so these are the two important differences, right? Now, what happens in water loading test? In spite of giving excess amount of water, still these individuals will be having the, whenever you are giving excess amount of water, what should happen to your ADH level? The ADH level should decrease. But in spite of giving excess amount of water, the ADH levels are still high. The ADH levels are still high. That is what is your water loading test. Now, let me try to quickly, yeah. And what are the other investigations? Yes, the other investigations are in these individuals with SAIDH. Let me discuss particularly. The serum sodium levels will be decreased. Why? Because compensatory mechanisms are activated in such a way that the sodium is kicked out. So urinary sodium increases. Now, when serum sodium decreases, what will happen to plasma osmolality? Decreases. When urinary sodium increases, what will happen to your urinary osmolality? That will be increased. Okay, so these are the other investigations that you will have in patients with the SADH. And in patients with SADH, they will have normal blood pressure. They will not have hypertension. Why? Because there is inhibition of your sympathetic outflow. Then what about in diabetes insipidus? In diabetes insipidus, the serum sodium increases. Why? Because it's a free water excretion leaving behind the sodium back. So the serum sodium increases, and urinary sodium, either it may be normal or decreased. And what will happen to your plasma osmolality? Increases, and urine osmolality decreases in patients with diabetes insipidus. Then what about in diabetes mellitus? In diabetes mellitus, we don't discuss much about the serum sodium or urinary sodium because they remain normal, but the plasma osmolality, it remains normal or increased. When do you think that the plasma osmolality will be increased? That is in patients with hyperosmolar non-ketotic coma. There, the plasma osmolality increases. And what will happen to urine osmolality? The urine osmolality increases. Why? Because the urinary glucose levels are increased in patients with the diabetes mellitus. Then what about in psychogenic polydipsia? In psychogenic polydipsia also, the serum sodium and urinary sodium, more or less they remain normal or slightly they change. But what about the plasma and urine osmolality? Both of them are reduced. What is that? The question that they may ask you is, a patient presenting with, except for SADH, SADH you don't have polyuria, except for SADH, the remaining three scenarios, they will be presenting with polyuria, and they may give you any of these permutations and combinations, and they'll ask you what exactly is the diagnosis of the patient. Okay, right. Now, after having discussed about these patients with SADH, they will have euvolemic hyponatremia. It is not dilutional hyponatremia, right? And you may ask me why. Because of activation of compensatory mechanisms, like RAS is inhibited. When RAS is inhibited, sodium and water reabsorption does not occur. So along with sodium, water is also out. And there is stimulation of ANP, that is atrial natriuretic peptide, is activated. So that means what? Along with sodium, the water is also excreted out by natriuresis. So thereby, the individual with SAADH, they will not have hypervolemia. So they will not have edema. They will not have ascites. They will be having euvolemic status. Then in SAADH, what do you think is the drug of choice? In SAADH, let me tell you, the drug of choice will be the Vaptans. Drug of choice will be Vaptans. That is, you have Conivaptan and as well as the Tolvaptan. Conivaptan, it is given through intravenous route, and Tolvaptan you can give through the oral route. Okay. Now, SADH all are true except serum sodium can be less than 135. Urine sodium is normally or slightly low. Vaptans are approved drugs. Water loading test can be done. So remember, in case of SADH, what will happen to the urinary sodium? The urinary sodium increases. It will not be slightly normal or low. The urinary sodium increases in patients with the syndrome of inappropriate antidiuretic hormone. Okay, so this completes your pituitary disorder quick revision. Acromegaly, pituitary tumor, prolactinoma, hypopituitarism, diabetes insipidus, SAADH. All these are done. Now we'll move on to the adrenal gland disorders. Now coming to the next important topic, that is the Cushing syndrome. Right. So the Cushing syndrome, lady with central obesity and abdomen skin showing purple striae, what exactly is the diagnosis? That will be the Cushing syndrome. Now, if the question is asked, what do you think is the most common cause of the Cushing syndrome? The most common cause of the Cushing syndrome will be pituitary adenoma in this question. Pituitary adenoma in this question. But overall, what is the most common cause? Overall, the most common cause for Cushing syndrome will be the iatrogenic. That is external. So, most common cause of Cushing syndrome will be the iatrogenic, right? Iatrogenic steroid supplementation. And what is the most common cause of non-iatrogenic Cushing's? That will be the pituitary adenoma. And what is the most common cause of ACTH dependent type of Cushing's? Again, the answer is pituitary adenoma. And what is the most common cause of ectopic ACTH producing excess Cushing's? That will be your small cell carcinoma, right? And what is the most common cause of ACTH independent type of Cushing's? That will be the adrenal adenoma. So there are totally 5 questions on the most common etiologies of the Cushing's. Now, if the question is asked, what is the earliest manifestation of Cushing's? That will be the weight gain. And you know what will be the problem because of weight gain? Because of this weight gain, the individual can develop the central obesity. And because of the central obesity, the individual develops the insulin resistance. And because of the insulin resistance, the patient will develop the diabetes mellitus. The patient will develop diabetes mellitus. Okay, that is the earliest manifestation in the Cushing's. Now, then followed by that, what will be the skin manifestations in patients with the Cushing's? So, the skin manifestations, they include the purple striae, right? Why is that? That is because of stretching of the skin, because of the accumulation of the free fatty acids beneath the skin, and they will have easy bruisability. Why is that they will have easy bruisability? That is because of loss of the subcutaneous fat. Then these patients, they can also have hyperpigmented skin. But which type of Cushing's you will have hyperpigmented skin? That is ACTH dependent type of Cushing's. You will have ACTH dependent type of Cushing's, you will have the hyperpigmented skin. Now, ACTH dependent type of Cushing's, why do you have hyperpigmented skin? Because along with ACTH, the MSH is also produced in excess quantity, and that is the reason why they will be having hyperpigmented skin. That is mainly in case of the pituitary adenoma. What type of pituitary adenoma? Corticotroph type of pituitary adenoma. Next, which of the following feature is not seen in Cushing syndrome? Hypoglycemia, hypertension, frank psychosis, and then the hypokalemia. Let me tell you, in patients with Cushing syndrome, hypoglycemia will not be there. What they will have is, they will have hyperglycemia. The remaining all, hypertension, psychosis, and hypokalemia will be there in patients with the Cushing syndrome. Then, what is a true statement about the Cushing syndrome? Red striae, increased adrenaline, proximal muscle weakness, and edema. So true statement, please remember, these individuals, they can have proximal muscle weakness and they will also have edema. So why is that they will have edema is, that is because whenever there is excessive steroids in patients with Cushing's, this excess steroids will go and stimulate the epithelial sodium channels which are present on the distal convoluted tubule. And this epithelial sodium channels, when they are stimulated excessively, they will cause increased sodium and water reabsorption. Once there is increased sodium and water reabsorption, that will result in the edema in patients with the Cushing syndrome. Proximal muscle weakness will be there because excessive steroids will cause proteolysis, and proteins are present mainly within the muscles, and that is the reason why there will be proximal muscle weakness. And they will not have red striae, what they will have is the purple striae. And they will not have increased adrenaline, what they will have is increased steroid levels. Right, now after having discussed about the clinical features, how do you work up these patients with the Cushing's is a very, very important point. You see the clinical scenario. That is, a 28-year-old woman has noticed a change in her appearance. Most notably, her clothes do not fit properly and especially tight around the waist. Her face appears flushed and more rounded than usual. Despite exercising regularly and eating healthily, her weight has steadily increased over the last 3 weeks. That means weight gain is there. On visiting her general practitioner, he notices her blood pressure is increased since her last visit. She has bruises on her arms. She is especially worried about a brain tumor. The most appropriate investigation would be low dose dexamethasone suppression test, high dose dexamethasone suppression test, urinary catecholamines, CT scan, urinary free cortisol levels. So what do you think is the investigation of choice in these individuals? No, it is not low dose dexamethasone suppression test. Very, very important question. The first line investigation will be 24-hour urinary free cortisol level. So when you are suspecting Cushing's, right, the first line investigation will be 24-hour urinary free cortisol levels. Only when the 24-hour urinary free cortisol level test, if it is equivocal, right, if it is equivocal, then you should do this low dose dexamethasone suppression. Otherwise, the first line investigation will be the 24-hour urinary free cortisol levels. Now, if you take the workup in these patients with the Cushing's, like I'll just do a quick workup. So what is the first thing? That is the 24-hour urinary cortisol levels have to be tested. If 24-hour urinary cortisol levels are being elevated, what is the next thing that you need to do? The next thing that you need to do is you need to check for the ACTH levels, right? If ACTH levels are elevated or ACTH levels are reduced. ACTH levels are reduced means it is adrenal adenoma or adrenal carcinoma. So immediately you need to do CT or MRI of the abdomen. What is that to look for? That is mainly to look for adrenal adenoma or adrenal carcinoma. And if ACTH levels are elevated, that tells you it is ACTH dependent type of Cushing's. So now, ACTH dependent type of Cushing's, you have two sources. One is pituitary adenoma, the other one is ectopic ACTH secretion. So here you need to do high dose dexamethasone suppression test. right? High dose dexamethasone suppression test. So with high dose dexamethasone suppression test, please remember that with high dose dexamethasone, if steroid levels are reduced, right, that tells you it is pituitary adenoma. And even with high dose dexamethasone, if steroid levels are still high, that means it is ectopic ACTH. And if it is an ectopic ACTH, what is that you need to do? You need to do CT and MRI of the abdomen and as well as thorax. What is that you will rule out by doing CT and MRI of the abdomen and thorax? See, why is that you have to do thoracic CT or MRIs? To rule out small cell carcinoma or medullary carcinoma of thyroid. And why is that you need to do the abdominal x-rays, sorry, abdominal imaging is because that is mainly to rule out the pheochromocytoma, because the pheochromocytoma, small cell carcinoma of the lung, medullary carcinoma of thyroid, and pancreatic and bronchial carcinoids. These four conditions are the ectopic sources for ACTH. So mainly to rule out them, you need to do CT or MRI of the abdomen and as well as thorax. And once you suspect that it is the pituitary adenoma, then what is that you will be doing is you will be doing the MRI of the pituitary. That is mainly to look for the size of the tumor. Okay. Now, if the MRI of the tumor is normal, you are suspecting pituitary tumor, but if the MRI of the MRI is normal, then you need to do inferior petrosal venous sinus sampling, right? Inferior petrosal venous sinus sampling. So this is the workup that you will be doing in patients with the Cushing syndrome. Now, if the question is asked, what is the earliest biochemical change in Cushing's? The earliest biochemical change in Cushing's will be loss of diurnal variation. In a normal individual, early in the morning, steroid levels will be high. Later in the night, the steroid levels will be low. But in Cushing's, everything will be, early in the morning also it will be high. Late in the evening also it will be high. That is the earliest change in patients with the Cushing syndrome. Then you see this question. A 50-year-old male chronic smoker presents with history of hemoptysis. He was he was having truncal obesity and hypertension. He had elevated ACTH levels, which was not suppressible with high dose of dexamethasone. What would be the most probable diagnosis in this clinical scenario? So the patient is a smoker, hemoptysis. In spite of doing high dose dexamethasone, the steroid levels are still high. That means it is an ectopic ACTH producing lung cancer, right? Now let us discuss the treatment in patients with the Cushing's. So patient is having the Cushing syndrome due to adrenal tumor. What is the drug of choice? See, actually, in Cushing syndrome, what is the treatment of choice? In Cushing syndrome, the treatment of choice will be the surgical resection. The treatment of choice will be surgical resection. That is a treatment of choice. But if the individual is having contraindications for surgery, then you need to give medical management. And what is the drug of choice for that? The drug of choice for that will be the ketoconazole. And what is this ketoconazole? Ketoconazole is an antifungal drug. But why are we giving antifungal drug in Cushing's? Because the ketoconazole, it also causes adrenal enzyme inhibition. Thereby, the corticosteroid synthesis does not occur. So that is the reason why ketoconazole is considered as the drug of choice. It will cause medical adrenalectomy. It will cause medical adrenalectomy. So it's an adrenal enzyme inhibitor. And what is another drug which is an adrenal enzyme inhibitor? That is intravenous etomidate. Okay. Now, the adrenolytic agent is the metotine. And there are certain drugs which will target the pituitary, that is cabergoline and as well as the paclitaxel. That is about the medical management. But what is exactly the treatment of choice? Surgical resection of the tumor. But the problem is, right? But the problem is that if the patient is having bilateral adrenal adenoma or bilateral adrenal carcinoma, in such case, what happens? You need to do bilateral adrenal resection. So, when you do a bilateral adrenalectomy, steroid levels are completely reduced. When steroid levels are completely reduced, what will happen to ACTH levels in the pituitary? Increases. MSH increases. When MSH increases, that will cause the hyperpigmentation. Okay. So in Nelson syndrome, secondary to bilateral adrenalectomy, there will be hyperpigmented skin. So that is the reason why whenever you do bilateral adrenalectomy, immediately you need to give hydrocortisone. If you don't give hydrocortisone, then the patient may develop the Nelson syndrome, where the individual will have hyperpigmented skin. So this completes the Cushing syndrome. Okay. Right. And one important thing that you need to know is like about the ectopic ACTH. What is the most common cause for ectopic ACTH? Small cell carcinoma of the lung. In such case, you need to give cisplatin and as well as the irinotecan. Okay. Right. So this was about the Cushing's. Now we'll move on to the next important adrenal gland disorder, that is the Conn syndrome. What exactly is your Conn syndrome? It is nothing but the hyperaldosteronism. So if the question is asked, what is the most common cause of the Conn syndrome? The most common cause of the Conn syndrome, please remember, it is adrenal adenoma. But if the question is asked, what is the most common cause of primary hyperaldosteronism? That will be bilateral adrenal hyperplasia. Right, bilateral adrenal hyperplasia. Okay, that will be the most common cause for primary hyperaldosteronism. Okay, now, so if you see here, most common cause of Conn's, adrenal adenoma. Most common cause of primary hyperaldosteronism, that will be the bilateral adrenal hyperplasia. Now, whenever in Conn's, what is happening? There is hyperaldosteronism, right? So there is increased sodium and water retention. There is potassium excretion causing hypokalemia, and there is H+A1 excretion causing metabolic alkalosis. So because of increased sodium and water retention, these patients, they will have diastolic hypertension. But very important point you need to know is that they will not have edema and they will have polyuria. Why is that there is no edema and why is that they will have polyuria? That is because of aldosterone escape phenomenon. Okay, right. Then hypokalemia. Because of hypokalemia, the patient will have very severe muscle weakness, and they will also have the ventricular arrhythmias, that is VT or VF, where the individual can have sudden cardiac death. And because of increased excretion of H+A1, the patient can have metabolic alkalosis. So these are the features of the primary hyperaldosteronism. Now, if you take the differences between primary and secondary hyperaldosteronism, what do you mean by the word primary? That means the pathology is within the gland. What do you mean by the word secondary? That is due to decreased renal perfusion. What would be the causes for secondary hyperaldosteronism? That would be because of cirrhosis of liver and as well as congestive heart failure. Any condition which is causing decreased renal perfusion can cause secondary hyperaldosteronism. So in primary, what will happen to renin levels? Decrease. Why? Because in primary, there is pathology within the gland where there is increased sodium and water retention, fluid level increases, renal perfusion increases, so RAS gets inhibited, so there will be decreased renin. Whereas in secondary, due to decreased renal perfusion, secondary hyperaldosteronism is occurring, so there will be increased renin. Okay, and in both of them, there will be increased aldosterone. But what about aldosterone renin ratio? Aldosterone renin ratio is increased in primary, but whereas in secondary, it will be normal or it will be increased in secondary hyperaldosteronism. And what are the causes for secondary hyperaldosteronism? That is your cirrhosis of liver and congestive heart failure. Now, what is the screening test for your Conn syndrome? Screening test will be the aldosterone renin ratio, right? Aldosterone renin ratio is increased. That is a screening test. But what will be the confirmatory test? That is oral salt solution test and IV saline suppression test. So what is this? Like in spite of giving oral salt solution or in spite of giving IV saline, the aldosterone levels will still remain high. That will be the confirmatory test for your primary hyperaldosteronism, right? Then what is the treatment of choice in primary hyperaldosteronism? Remember, it is a surgical resection. That is the primary treatment or treatment of choice. But the problem comes for suppose if the individual is having bilateral adrenal hyperplasia, when you do bilateral adrenalectomy, then even steroid levels also will be reduced. So that is the reason why whenever there is bilateral adrenal hyperplasia, in such case, you need to give aldosterone antagonist, that will be spironolactone or eplerenone is being supplemented, which is nothing but aldosterone antagonist. Now, you see this clinical scenario. Prior to testing for the hyperaldosteronism, the patient ideally need to hold all the medications except diuretics, ACE inhibitors, NSAIDs, verapamil. See, aldosterone escape phenomenon, what exactly is this is, see, in patients with Conn syndrome, there is, or in patients with your hyperaldosteronism, there is increased sodium and water retention. So once there is increased sodium and water retention, subsequently that increased sodium and water has to go to the kidney itself, right? So kidney will be continuously loaded with water in Conn syndrome. So the renal threshold for absorption of water is gone. So kidney says, I cannot bear this much large quantity of water which is continuously coming to me. So the renal tubules will lose their renal threshold. So thereby the individual will have polyuria because renal threshold is lost for the renal tubules, right? Thereby the individual will have polyuria. Once there is polyuria, there is no edema. And why am I calling it as aldosterone escape phenomenon? That means in spite of aldosterone being present in high quantities, water reabsorption is not taking place because of crossing of the renal threshold by renal tubules. Aldosterone is escaping its action. So that is the reason why it is called aldosterone escape phenomenon. Right. So the correct answer here will be the verapamil. Okay. The remaining all drugs can alter the levels of aldosterone. Whereas verapamil does not alter the levels of aldosterone. So holding of your verapamil prior to testing of hyperaldosteronism is not required. Okay. So this is about your Cons syndrome. Now, after having discussed about cons, then we'll move on to the next important topic, that is Addison's. Okay. Now I'll just show you a quick question related to Addison's. What exactly is your Addison's? That is adrenocortical insufficiency. That is what is called the Addison's. Okay. Right. So the question is, a 22-year-old female presenting with dizziness, feeling lightheadedness. She works in an office and most frequently experiences this when standing up to visit the toilet. She never fainted. The patient has lost 5 kg but attributes this to eating more healthily. She has noticed a recent scar on her back of her hand that started to turn very dark. The most appropriate investigation in this patient will. So first of all, you should be able to diagnose this clinical scenario. So the diagnosis of this clinical scenario is the Addison's. Now, what are the points to tell that it is Addison's? Number one, dizziness and feeling lightheadedness. Why? Because the patient will be having hypotension. And whenever she stands up for going toilet, the dizziness increases, which is nothing but your postural hypotension secondary to hypoaldosteronism. Okay. And the point is losing weight. Why the patient has lost weight? Because there is decrease in steroid levels in this patient. And the next point is turning very dark. Why is that? That is because of increase in the MSH levels in patients with the Addison's. There will be hyperpigmented skin. So now in Addison's, what do you think is the investigation of choice? Very good, Himanshu Patel. That is the synactin test. This particular synactin test, which is also called co-syntopin test. Right, this is also called co-syntopin test. Okay. Now this adrenocortical insufficiency, right, this is of two types. What is that? One is primary adrenocortical insufficiency and secondary adrenocortical insufficiency. The word primary means the pathology is within the gland. That means all the 3 adrenal cortical hormones are reduced. That is steroids, aldosterone, weak sex hormone, everything gone. Whereas in secondary hyperaldosteronism, that is due to pathology in anterior pituitary. That means that there will be decrease in your ACTH levels. So once there is decrease in ACTH, only steroids will be reduced and as well as the weak sex hormones will be reduced. Why? Because aldosterone production is not dependent on ACTH. So that is the reason why only steroids and as well as weak sex hormones will be reduced in secondary. Now the MSH levels are increased in patients with primary. Why is that they are increased? Because when steroid levels are reduced, the anterior pituitary will try to produce excess amount of ACTH, thereby there is increased MSH that will be causing hyperpigmented skin. Whereas in secondary adrenocortical insufficiency, there is decreased ACTH. Once there is decreased ACTH, there will be decreased MSH, thereby there will be hypopigmented skin, and this we call it as the alabaster skin. This we call it as alabaster skin. Okay, so hyperpigmented skin will be there in hypopigmented skin will be there in secondary adrenocortical insufficiency. Now, if you take the etiology of the adrenal insufficiency, most common cause of adrenal insufficiency in India, so remember it will be tuberculosis. Whereas most common cause of adrenal insufficiency in West, that will be the autoimmune adrenalitis. So these are the 2 points. So in India, it is tuberculosis. In the West, it is the autoimmune adrenalitis. And if the question is asked like what is the most common fungal infection that will be causing the Addison's, that will be your histoplasmosis, right, which can cause the adrenal hemorrhage causing the hypoadrenalism. Then viral infection causing your Addison's, that will be your cytomegalovirus. Now we have a clinical condition called adenomyeloleukodystrophy which will be causing Addison's. And what exactly is adenomyeloleukodystrophy? It is an X-linked disorder and most commonly seen in males. And these patients also have neurological degeneration. And in adenomyeloleukodystrophy, let me tell you, along with adrenal insufficiency, why is that adrenal insufficiency? That is due to accumulation of very long chain fatty acids within the adrenal gland, and that is the reason why there is adrenal insufficiency, adenomyeloleukodystrophy. And what are the infiltrative disorders that can cause Addison's? That includes sarcoidosis, where there is non-caseating granuloma accumulating within the adrenal gland. Then hemochromatosis, where there is excessive iron accumulating within the adrenal gland. Then the amyloidosis, where there will be abnormal protein which gets accumulated within the adrenal gland, resulting in Addison's. Then what are the malignancies causing Addison's? Malignancies include leukemia and as well as the lymphoma, right? Then what are the secondary causes? Secondary causes means the pathology should be in the anterior pituitary, that is the pituitary insufficiency. These are all the etiologies that will be causing the adrenal insufficiency. Now, what do you think will be the clinical features of adrenal insufficiency? See, because of glucocorticoid insufficiency, there will be weight loss, there will be lack of energy, there will be hypoglycemia, there will be hypotension, the individual can have fever, the individual can have anemia, eosinophilia and lymphocytosis. Whereas mineralocorticoid insufficiency, they'll have hyponatremia, because of which there will be salt craving, right? And what will happen to sodium and water retention? Does not occur. What will happen to potassium levels? Hyperkalemia. And what will happen to your H plus ion level? Increases, resulting in metabolic acidosis, right? And adrenal androgen deficiency, that is, these features are very common in females, where there will be loss of libido in females, there will be loss of secondary sexual characteristic features, there will be loss of axillary hair, there will be loss of pubic hair because of the adrenal androgen insufficiency. And other signs and symptoms, just now we have discussed. In primary, you will have hyperpigmented skin, and in secondary, you will have the hypopigmented skin. And in hyperpigmented skin, in case of Addison's, where exactly you will observe? That is mainly within the palm and as well as sole creases. So you can observe that here. And the other places where you can have the hyperpigmentation is the areola, axilla, cubital fossa, groin, oral mucosa, and as well as the nails. So these are all the places where you can have the hyperpigmented skin. One of the very important condition that you need to know in Addison's is the Waterhouse-Friderichsen syndrome. Waterhouse-Friderichsen syndrome is what? It is acute adrenal insufficiency secondary to Neisseria meningitis. That is nothing but your meningococcal infection. So acute adrenal insufficiency, and it is secondary to meningococcal infection. The patient will present with the cardiovascular collapse. The patient may land up in coma and death also. And they will have significant hypotension. The drug of choice will be the hydrocortisone. Why is that we are giving hydrocortisone? Because hydrocortisone, it has a dual activity. It has steroid activity and it also has the mineralocorticoid activity. And that is the reason why we are giving hydrocortisone, not the dexamethasone, right? So in Addison's, what do you think is the most diagnostic test? The most diagnostic test will be the ACTH stimulation test, which is also called the cosyntopin test, right, which is also called synactin test, right, which is also called synactin test. So this is what is the investigation of choice. What exactly happens here is you give a cosyntopin. What is cosyntopin? It is an ACTH analog. How much of cosyntopin we need to give? 250 micrograms of cosyntopin you should give. So whenever you give 250 micrograms of cosyntopin, what it should do? It will stimulate the serum cortisol production. If serum cortisol production is more than 500, normal. If serum cortisol levels are less than 500 nanomoles in spite of giving cosyntopin, then we consider this particular patient is having the Addison's. Okay, that is how you will diagnose. Then what will be the CT scan appearance in Addison's? That is the moth-eaten appearance. Then what is the drug of choice in primary adrenocortical insufficiency? That is, you need to give hydrocortisone. Because in primary, all the three hormones are reduced: mineralocorticoids, steroids, and as well as weak sex hormones. We want the dual activity, mineralocorticoid activity and steroid activity, which will be there for your hydrocortisone. That is the reason why hydrocortisone is considered as the drug of choice. Whereas you take in secondary and tertiary adrenocortical insufficiency, what will happen? Here there is only steroid reduced. Mineralocorticoid levels will be normal. So that is the reason why we give a potent steroid. And what will be that potent steroid? This particular potent steroid is your dexamethasone. Okay. Yes, phenomenal. This Waterhouse-Friderichsen syndrome, it is more commonly seen in children and as well as newborn. Okay, right. So this is about your Addison's. Okay. Now next we'll move on to the next important endocrine disorder, that is the pheochromocytoma. What exactly is your pheochromocytoma? It's a tumor which is originating from the adrenal medulla. So it is a tumor which is originating from the neuroendocrine cells of the adrenal medulla. Neuroendocrine cells of adrenal medulla. Now, what is a predominant hormone which is being produced from pheochromocytoma? That is norepinephrine. And this adrenal medullary tumor, that is your chromaffin cells, are not present only in adrenal medulla. You also have extra-adrenal pheochromocytomas. Now, what do you think is the most common extra-adrenal pheochromocytoma? Please remember, it is organ of Zuckerkandl. What is organ of Zuckerkandl? Organ of Zuckerkandl, it is a chromaffin body which is present in abdominal para-aortic area, right? And that is the most common site for extra-adrenal pheochromocytoma. Even this one also will produce the norepinephrine in excess quantity. Now, in patients with pheochromocytoma, what will be the most common symptom? Most common symptom will be the headache. What will be the most common sign? That will be the hypertension. And this particular headache will be mainly the occipital headache. Then what is the triad in pheochromocytoma? The triad in pheochromocytoma will be headache, then profuse sweating, then palpitations. This is what is a triad in pheochromocytoma. All of the following are the clinical features of pheochromocytoma except increased hematocrit, orthostatic hypotension, low cortisol level, impaired glucose tolerance. Please remember, in pheochromocytoma, they will not have low cortisol levels. Low cortisol level is a feature of Addison's. What about hematocrit? Increases in this patient. What about glucose? Glucose levels increases in these patients with the pheochromocytoma. Now, if you take the investigation of choice, or what is the first line investigation for screening? First line investigation for screening will be 24-hour urinary fractionated metanephrine levels, right? That will be elevated. That is the first initial screening test. Then what is the confirmatory test? The confirmatory test will be the plasma metanephrine levels. And how many times it should be elevated? More than 4 times. If it is elevated less than 4 times, then you need to do clonidine suppression test. Why? Because less than 4 times, it could be because of pheochromocytoma, or it could be because of the increased anxiety also, which will be causing excessive sympathetic outflow. And when you give clonidine to the patient who is having increased anxiety, then your epinephrine and norepinephrine will become normalized. But in patients with your pheochromocytoma, even in spite of giving clonidine, the epinephrine and norepinephrine will be still on the higher side. So that will be the confirmatory test in patients with your pheochromocytoma. And extra-adrenal pheochromocytomas. Extra-adrenal pheochromocytomas. Okay. Yes, what is your question? Orthostatic, okay. Yes, Himanshu Patel and all of you have answered. Orthostatic hypotension will be there in patients with pheochromocytoma. Why? Because in patients with pheochromocytoma, you will have blunting of the sympathetic reflexes. Right? You will have blunting of sympathetic reflexes. And that is the reason why you will have orthostatic hypotension in pheochromocytoma. Alright? Next, then, now, if you take the localization of the tumor, so extra-adrenal pheochromocytomas, they are being localized predominantly by gallium-68 dotatate scan. That is the most sensitive scan for localizing the extra-adrenal pheochromocytoma. Okay, right. Now, if you take that urinary metanephrine, what is that we were measuring? That is VMA. VMA is definitely elevated in pheochromocytoma, no doubt in that. But what are the other conditions where VMA levels can be elevated? VMA is elevated in which of the following conditions? Primary micronodular adrenal hyperplasia, cons, neuroblastoma, and tuberous sclerosis. Please remember, along with your pheochromocytoma, even in case of neuroblastoma, the vanillin mannalic acid levels are being elevated. Okay. Now, how do you treat these patients with a pheochromocytoma? It's a very, very important question. So, you see the question here. A 65-year-old woman complains of the panic attacks. She has recently retired as a school teacher, but 2 to 3 times a week she suffers extreme anxiety, shortness of breath, and sweating profusely. Elevated catecholamines are detected in the urine. What is the most appropriate treatment? So, what is this diagnosis suggestive of? That is pheochromocytoma. Panic attacks, anxiety, palpitations, profuse sweating, elevated catecholamines. Diagnosis is pheochromocytoma. So, in pheochromocytoma, like, what is the treatment of choice? The treatment of choice will be actually surgical resection of tumor. But the point is that whenever the blood pressure is on the higher levels, then we don't do surgical resection until the blood pressure is achieved less than 160 by 90 millimeters of mercury. So to achieve the blood pressure of less than 160 by 90, what is that you need to do? You need to give the alpha blocker first, that is phenoxybenzamine, then followed by that propranolol. You achieve this blood pressure, then you need to do surgical resection. Okay, so the correct answer in this patient is the C, that is phenoxybenzamine followed by that propranolol. And you should never give beta blocker in the patients first. You should never give beta blocker first. First alpha blocker, then followed by that the beta blocker. So what do you think treatment of choice in pheochromocytoma? That will be the surgical resection of the tumor. Okay, right. Then, so we are done with the adrenal gland disorders. What is that? Cushing's, Cons, Addison's, pheochromocytoma. Now let us discuss the parathyroid disorders. Okay, we have hyperparathyroidism and hypoparathyroidism. 10 minutes, this will be done. So the most common cause of primary hyperparathyroidism is, so carcinoma, solitary adenoma, chronic renal failure, hyperplasia. Remember, it is the solitary adenoma of parathyroid. That is the most common cause of hyperparathyroidism. So now this hyperparathyroidism, we classify that into, the primary, then secondary, then ectopic causes for hyper. Primary means what? The pathology is within the parathyroid gland itself. That is solitary adenoma of parathyroid gland is the most common cause for primary hyperparathyroidism. Then the other etiologies are parathyroid carcinoma and parathyroid hyperplasia. Secondary causes are what? Secondary causes are mainly secondary to the hypocalcemia. So whenever the calcium level reduces, secondary to that, parathormone levels will be released. That is called secondary. That is chronic renal failure. You will have hypocalcemia. Vitamin D deficiency, you will have hypocalcemia. Medullary carcinoma of thyroid, you will have hypocalcemia. So that is about your secondary hyperparathyroidism. Then ectopic causes of hyperparathyroidism, that includes squamous cell carcinoma of the lung and adenocarcinoma of the kidney. So these are the ectopic causes for hyperparathyroidism. Now, whenever there is hyperparathyroidism, what will be the problem? One, there will be increase in your calcium levels, and where is this calcium coming from? Bone. So there will be the bony abnormalities as well. So because of increase, normal calcium levels are how much? 9 to 11 milligrams per deciliter. When calcium levels are 11 to 12, there will be renal calculi, and because of this renal calculi, the individual will have the loin pain. Okay, now this particular loin pain will be radiating to the umbilicus, and this we call it as rhinogastric reflex. This we call it as rhinogastric reflex. Okay, then next important point is the skin, right? So these patients, they will have calcinosis cutis. Why? Because the calcium will be accumulated within the skin, and that we call it as the calcinosis cutis. And the calcium will get deposited even within the blood vessels, and that will result in the hardening of the blood vessels, and that we call it as the pseudo hypertension, right? And the calcium will also accumulate within the gastrointestinal sphincters, resulting in decrease in the gastrointestinal motility. Why is that? Because of the contraction of the sphincters. So the patient will have constipation, and the individual will also have abdominal pain. So these are the abnormalities due to increase in the calcium levels between 11 to 12. When the calcium levels are in between 12 to 13, the calcium will cross the blood-brain barrier and the calcium will deposit within the basal ganglia, and that will result in the secondary Parkinsonism. Now, when the calcium levels are 13 to 14, that is the point when the individual will have the systolic arrest and finally death of the individual, right? Systolic arrest and finally death of the individual. So these will be the abnormalities due to increase in the calcium levels. Okay, right? Yes, phenomenon. See, in case of medullary carcinoma of thyroid, this will be producing excess amount of calcitonin. Okay, what does this calcitonin do? Calcitonin will decrease the calcium. When there is decrease in calcium, that will cause secondary hyperparathyroid. Okay, yes, Sanamanan, did you understand this point? Okay, now yes, now you take the bony abnormalities. What did I tell you? Now the increased parathormone will cause bone resorption. So once there is bone resorption, subsequently there will be bone repair also. And in our body, what is the process by which the repair occurs? By fibrous tissue accumulation, and that we call it as the osteitis fibrosa cystica, where there will be fibrous tissue accumulation in the area where the bone has been resorbed. And within the spine, you have two important abnormalities. That is the codfish spine, that is because of the scooping of the vertebra by excess parathormone. Then you have Rugger Jersey spine, and this Rugger Jersey spine is nothing but alternate dark and white bands because of increased parathormone levels. And even within the skull, you will observe the pinhead stippling, that is because of bone resorption because of increased parathormone secretion. And this is what is your pinhead stippling. And not only that, you take the dental film. When you take the x-ray of the dental film, there will be absence of lamina dura. This is the lamina dura. What exactly is that? That is mineralization of the mandible. That will be lost because of the bony resorption. Okay, so and in these patients, you have a tumor also which is seen in hyperparathyroidism, and that we call it as the epulis tumor. That we call it as the epulis tumor. Okay, then how do you investigate these patients with hyperparathyroidism? See, in patients with hyperparathyroidism, what is that you will notice is, you will notice that there is increase in calcium levels. Okay, there is increase in parathormone levels, right? And there will be decrease in the phosphate levels or phosphorus levels. And what will happen to urine phosphate levels or urine phosphorus? Increases, right? And serum calcium level increases because there will be crossing of the renal threshold. And what will the DEXA scan show? DEXA scan show that there is decreased bone mineral density. And what will happen to your alkaline phosphatase levels? The alkaline phosphatase levels are elevated because that is a marker of your bony turnover. Then what is that scan which will localize that parathyroid tumor? That is the technetium 99M system EB scan, right? Technetium 99M sesame scan. So that will be the investigation in hyperparathyroidism. Then what is the treatment of choice in hyperparathyroidism? That is surgical resection of the parathyroid tumor. Surgical resection of parathyroid tumor. Then before surgery, you have to ensure that the calcium is being normalized, for which the calcium, for normalizing the calcium, like the first line treatment will be the IV fluids that will cause dilution effect, and along with IV fluids you also need to give furosemide that will cause flushing out of the calcium. And what exactly is the drug of choice? Ibandronate, that will prevent the bone resorption. What exactly is that? This is your bisphosphonates that will prevent the bony resorption, right? And the another important drug is antagonist of parathormone, that is calcitonin nasal spray. Calcitonin nasal spray, what it will do, it will see that the calcium will not be reabsorbed from the bone. So that is what is the treatment for your the hyperparathyroidism. Now, once we are done with hyperparathyroidism, then we'll come on to the discussion of the hypoparathyroidism. Okay, hypoparathyroidism. You see the clinical scenario. A 54-year-old woman presents to her general practitioner of a change in her breathing sound. She first noticed numbness, particularly in her fingers and toes, 3 months ago, but attributed this to cold weather. Her partner now reports hearing a high-pitched, harsh sound while she is sleeping. Her BMI is 27. While measuring the blood pressure, you notice the patient's wrist is flexing. What do you think is the diagnosis in this patient? Obstructive sleep apnea, hypocalcemia, Digeorge syndrome, Guillain-Barré, Raynaud's syndrome. The correct answer is the hypocalcemia. Right? All those, right? Numbness, perioral paresthesia and periungual paresthesia. And what is this particular sign? And this sign is nothing but the Troche's sign. This sign is nothing but the Troche's sign. So these are the features of your hypocalcemia, right? Now, what are the etiologies that will be causing hypoparathyroidism? That includes autoimmunity, and your thyroid surgery will cause acute hypoparathyroidism because there will be parathyroid resection. And one more important condition is the Digeorge syndrome. Now, how do you remember this Digeorge syndrome is? It's actually a genetic disorder. Remember this mnemonic, that is catch-22. What does this catch-22 stands for? C stands for cardiac abnormalities. A stands for abnormal phases. T stands for the thymic absence, that is thymic hypoplasia. C stands for cleft palate. H is your hypocalcemia, and abnormality is on chromosome 22. That is what is your Digeorge syndrome. Now, there are some of the important images in patients with hypoparathyroidism. That is, number one, Troche's sign. Right? You inflate the BP cuff. Within 1 to 2 minutes, you will observe that there is the carpopedal spasm, and that we call it as Troche's sign. And what are the other signs? So this is your Troche's sign. Right? Now, can anyone tell me what exactly is this? Right? When you tap the facial nerve at the angle of mandible, you tap the facial nerve at the angle of mandible. What is that you will observe? You will observe the spasm of the muscles on that half of the face. So this is called as the Chostek sign. Right? This is called as the Chostek sign. Okay? Right? These are the two important signs. Now, you take this word Troche's. We have two other conditions where you come across this Troche's sign and Troche's syndrome. That is Trocher's sign, which is nothing but your Virchow's lymph node. Right? Virchow's lymph node. Okay? Where the supraclavicular lymph node will be enlarged. And where do you come across this? In patients with carcinoma of the stomach. Carcinoma of the stomach will metastasize to the left supraclavicular area, and that we call it as the Virchow's lymph node. Okay? And the next important sign is the Trocher's syndrome. That is migratory thrombophlebitis. You come across this in patients with a pancreatic cancer. Okay? And in patients with hypocalcemia, that is in hypoparathyroidism, you will have hypocalcemia. And in hypocalcemia, you have the long-term skeletal abnormalities. What is that long-term skeletal abnormalities? That includes genu valgum and then genu varum. Genu valgum is your bow legs. I'm sorry, knock knees. And genu varum is your the bow legs. So these are the bony abnormalities that you will come across because of the hypocalcemia, right? And the other important is the treatment of the hypoparathyroidism. The treatment of hypoparathyroidism, you need to give calcium gluconate and as well as vitamin D supplementation. Now, in hypoparathyroidism, we have one form of hypoparathyroidism that we call it as the pseudo hypoparathyroidism. Right? Pseudo hypoparathyroidism. Here, parathormone is present in adequate quantities, but parathormone receptors are resistant. And why is that parathormone receptors are resistant? That is due to mutation of the gene, that is GNAS gene. Okay, and in these individuals, because parathormone receptors are resistant, parathormone is not able to show its action, so there will be hypocalcemia in this patient. Okay, now what do you think will be the clinical features? They'll have all the clinical features of your hypocalcemia. Along with that, you have this classical Albright hereditary osteodystrophy. What exactly will be the features of Albright hereditary osteodystrophy? They'll have short stature, right? There'll be abnormality within the eyes and as well as even within the ear, right? There will be defective olfaction, and they'll have short fourth and fifth metacarpal bone, right? They'll have short fourth and fifth metacarpal bone. And these patients, what exactly will be the treatment? That is calcium supplementation. Now, because of this short fourth and fifth metacarpal bone, whenever they make a fist, you will observe that there is a knuckle, but here at this point, you will notice that there is a dimple, right? At this point, you will notice that there is a dimple. So this is knuckle dimple sign that you come across in patients with pseudo hypoparathyroidism, okay, which is a part of Albright hereditary osteodystrophy. And what is the differential diagnosis for this? That is in Down syndrome, where third metacarpal will be short, where you will have knuckle dimple knuckle sign. And the other condition is that the Turner's, in Turner's, fourth metacarpal will be short. Because of that, when they make a fist, you'll have knuckle dimple knuckle sign. Okay, knuckle dimple knuckle sign. So this is what is your Turner syndrome. Okay, so this is about your parathyroid disorders. This is about your parathyroid disorders: hyperparathyroidism, hypoparathyroidism, and as well as pseudo hypoparathyroidism. Okay, right. Next, yes, you see this question. A 33-year-old obese woman complains of tiredness. She has recently given birth to a healthy baby boy, is enjoying being a mother. However, she is becoming more reliant on her parents for support as she always feels exhausted and often becomes depressed. The patient has a poor appetite and often does not finish her meals. Despite this, she gained a weight of 5 kg in the last 2 weeks. Most likely diagnosis: postpartum depression, eating disorder, hyperthyroidism, hypothyroidism, and then occult malignancy. So, what do you think is the correct answer here? See, it is a case of the hypothyroidism. Why? Because easy fatigability, the patient is tired, depression, weight gain, decreased appetite. All these are points in favor of hypothyroidism. In case of postpartum depression, you don't have that weight gain. So, this is ruled out. Okay, and in case of eating disorder, you will not have the poor appetite, right? And in hyperthyroidism, there will be weight loss, not weight gain. And in malignancy also, there will be weight loss, not the weight gain. Okay, so the answer here is hypothyroidism. So what is that we'll discuss now? We'll discuss the thyroid disorders in just 10 minutes. Okay, right. So you take this thyroid disorders. Most common cause of hypothyroidism in India, that will be the Hashimoto's thyroiditis. Most common cause of hypothyroidism globally, that will be the iodine deficiency. Now, if you take Hashimoto's is what? It's an autoimmune disorder, and in this disorder, it is characterized by the infiltration of T lymphocytes. These T lymphocytes, they will infiltrate your follicular cells and they will destroy the follicular cells by producing the antibodies. In spite of destruction of follicular cells, some follicular cells, they are still surviving and they are filled with the pink colloid, and that we call it as the Hurdle cells. That we call it as Hurdle cells. Now, being an autoimmune disorder, what are the antibodies in Hashimoto's? So, if you take the antibodies in Hashimoto's, that includes anti-thyroglobulin antibody, anti-microsomal antibody, antibody which is directed against the component of colloid, antibody which is directed against the TSH receptor. So, these are the antibodies in Hashimoto's thyroiditis. Okay, very important. And remember, these antibodies does not tell you about the severity of the disease. These antibodies, they are only of diagnostic importance. Okay, they don't tell you about the severity. Now, if you take the etiology causing hypothyroidism, there are many etiologies, but what is very important thing that you need to know? The drugs. The drugs which will be causing hypothyroidism will be amiodarone, lithium, paraminosalicic acid, cytokines, then interferon alpha. These are all the drugs which can cause the hypothyroidism. Now, apart from that, there are some infiltrative disorders that will be causing hypothyroidism. What is that? The infiltrative disorders, some abnormal material like amyloidosis, sarcoidosis, hemochromatosis, cystinosis, and then the other condition is the scleroderma, where there will be abnormal collagen which will be accumulating. Okay, right. Then, after having discussed about the hypothyroidism, you see the another scenario. A 42-year-old woman presents with visual disturbances. She reports having double vision, which was intermittently initially but has now become much more frequent. In addition, she becomes breathless very easily and experiences palpitations. On examination, raised painless lesions are observed on front of her shin and there is finger clubbing. What do you think is the most likely diagnosis in this patient? Yes, what do you think is the most likely diagnosis in this patient? Decurvain thyroiditis, thyroid storm, pheochromocytoma, Graves' disease, and then the plumber's disease. So the correct answer here will be yes. So the correct answer in this particular patient will be the Graves' disease. Why? Because like the patient is having the history of the palpitations, the history of the weight loss, the history of the clubbing of the fingers, history of the painless lesions which are observed in front of shin of the tibia, which is nothing but the pretibial myxedema, right? Which is nothing but the pretibial myxedema. So all these points are in favor of your Graves' disease. And what exactly is your Graves? I will discuss the other options also subsequently. What exactly is your Graves? Graves is the most common cause for your hyperthyroidism and it is an autoimmune disorder. And the antibodies are thyroid stimulating immunoglobulin. And not only this autoimmune disorder that will be causing hyperthyroidism, please remember, even we have drugs which will be causing hyperthyroidism and that is nothing but your amidorone. Now this amidorone, it can cause both. It can cause hypothyroidism and hyperthyroidism. So accordingly, you have right. So accordingly, you have autoimmune thyroiditis type 1 and autoimmune thyroiditis type 2. Now, what is this autoimmune thyroiditis type 1? Autoimmune thyroiditis type 1 is that which is seen in individuals who is having preclinical Graves or some abnormal multinodular goiter. So that means there should be an underlying thyroid abnormality for an individual to develop amidorone induced thyroiditis type 1. And in case of amidorone, what exactly contains your amidorone? Amidorone, it contains the iodine. So it is iodine induced hyperthyroidism. It is nothing but your Jod base dose phenomenon. So in amidorone induced hyperthyroiditis type 1, there will be hyperthyroidism. Whereas, and what is that you will observe in the Doppler scan? It is hyperthyroidism. So you will observe there is increased vascularity on color flow Doppler on the thyroid scan. Whereas you take amidorone induced thyroiditis type 2. So in this, there is no underlying thyroid disorder in amidorone induced thyroiditis type 2. Now then why does it occur? This amidorone induced thyroiditis type 2, it is due to lysosomal activation, right? Lysosomal activation secondary to your amidorone, and that will cause the destruction of the thyroid. So thereby what will happen? Once there is destruction of your thyroid follicular cells, initially there will be hyperthyroidism, right? Initially there will be hyperthyroidism because what are the thyroid is there in the follicular cells will be released into the circulation, and later there will be hypothyroidism. That is what is your amidorone induced thyroiditis type 2, which is due to lysosomal activation. So because there is hypothyroidism, you will notice that there is decreased vascularity which is seen on the color flow Doppler. Okay, so that is about the story related to amidorone induced thyroiditis type 1 and as well as type 2. Himanshu, lithium, it will cause the hypothyroidism. Lithium causing hyperthyroidism is very, very rare. Okay, right. Now you take the next important clinical scenario related to thyroid. This is one of the very, very important PYQ. A 58-year-old woman presents with acutely painful neck. The patient has fever, blood pressure 135 by 85, heart rate 102. The patient explained pain started 2 weeks ago and gradually becomes worse. She also notes palpitations particularly and believes she has lost her weight. The symptoms subside and patient presents again complaining of intolerance to the cold, and the most likely diagnosis is, okay, you see here. So this particular patient is having a very painful neck. This particular patient is having a very painful neck, right? And this patient is having initially the features of the hyperthyroidism, losing weight, palpitations, and subsequently what is the patient telling? Intolerance to cold. Cold intolerance is what? That means it is your hypothyroidism. So initially you will have hyperthyroid features and later you are having hyperthyroid features with a painful neck. So what do you think is the diagnosis in this scenario? Right, the diagnosis in this scenario is your decurvain thyroiditis. What exactly is your decurvain thyroiditis? Decurvain thyroiditis is that which occurs secondary to viral infection, where the individual will have pain within the thyroid. It's an itis, it's an inflammation. So in the thyroid, you have the accumulation of the granulomatous tissue. That is the reason why it is also called granulomatous thyroiditis. And what is a granuloma? It contains the giant cells. That is the reason why it is also called giant cell thyroiditis. What will be the clinical presentation? So they'll have pain over the thyroid because it's an inflammation. They'll have fever and there will be enlargement of the thyroid gland. And even if you take the thyroid profile, what is that you will have early? That is hyperthyroidism. Why? Because the thyroid is inflamed. So there is excessive release of thyroid. Once that is over, the individual will have the hypothyroidism. And what will be the investigation of choice? You do biopsy of the thyroid gland. You will observe that there is presence of the giant cells. So that is about your granulomatous thyroiditis or giant cell thyroiditis or decurvain thyroiditis. And two other phenomena in thyroid that you need to know is the occurrence of hyperthyroidism following administration of supplemental iodine to subjects with endemic iodine deficiency goiter is known as Jod-Basedow, Wolff-Chaikoff, thyrotoxicosis factitia, and then decurvain thyroiditis. So it is iodine induced, right? Iodine induced hyperthyroidism. Iodine induced hyperthyroidism will be Jod-Basedow, whereas iodine induced hypothyroidism, that will be the Wolff-Chaikoff effect. Okay, that will be Wolff-Chaikoff effect. So please remember, Jod-Basedow, thyroid levels increased. Wolff-Chaikoff, it is off. So thyroid levels will be reduced. So iodine induced hypothyroidism is Wolff-Chaikoff. Okay, right. Then you need to know some of the important image based questions in the thyroid. So right, so if you take these image based questions, this is what you can have in the Graves, right, where you have the lid retraction, you have the proptosis, and you have that periorbital edema. So this is what is the picture that you will have in Graves. And if you take the skin in Graves, you have this pretibial myxedema, where you have the waxy skin which is being discolored, and there is also the induration and the presence of the beta carotenemia. The beta carotenemia, you come across this mainly in patients with the hypothyroidism. In hypothyroidism, you will have this beta carotenemia, right? Why is that? Because when thyroid hormone is not there, this beta carotene is not converted into vitamin A, and this beta carotene will get accumulated within the skin, and thereby you will get or you will have the yellow skin. Then how do you differentiate this from jaundice? In beta carotenemia, the eyes will be normal, whereas in jaundice, along with skin, even the eyes also will be yellowish in color. But whereas in beta carotenemia, the eyes will be normal. That is how you can differentiate. Okay. And next important image based question is, that is clubbing. That is what you come across in patients with thyrotoxicosis. And another endocrine disorder where you can have clubbing is the acromegaly. And what do we call this as? This we call it as thyroid acropathy. And whenever you do an imaging of this thyroid acropathy, what is that you will notice? You will notice that there is a periosteal calcification, right? Periosteal cortical thickening will be there. That is what you will observe in thyroid acropathy. Then another important image based question is myxedema. So how will be the appearance of the patient with hypothyroidism? That is, there will be round face, a dull looking face, and even the lips are swollen. And if you observe very clearly here, the lateral 1/3 of the eyebrows are being lost, and that we call it as madrosis. And the differential diagnosis for madrosis will be the leprosy, right? And the CNS examination, what is that you will observe is the hung up reflex. Where do you get this hung up reflex? That is in hypothyroidism. What is hung up reflex? Where there is delayed relaxation of the deep tendon reflex. Okay, and this is the image based question which has been asked multiple times. That is the Pemberton sign. Pemberton sign, where do you come across? In individuals with the retrosternal goiter. These patients with retrosternal goiter, on raising the arm, there will be facial flushing. Why is that? This particular goiter will compress the superior vena cava, thereby the venous drainage from the upper half of the face will not be there, and thereby there will be facial congestion. And how will you diagnose this retrosternal goiter? That is evaluated by CT or MRI of the thorax. Okay, right. Then which of the following can cause the profound hyperlipidemia? Hypoparathyroidism, hypothyroidism, hyperparathyroidism, hyperthyroidism. Remember, your dyslipidemia is very common in case of the hypothyroidism. in hypothyroidism, there will be increase in triglycerides, there will be increase in cholesterol. And because of this increase in triglycerides and increased cholesterol, these patients, they will develop premature atherosclerosis, and that can cause the coronary artery disease. That is what is the risk that you will come across in patients with the hypothyroidism. Then you have two extreme forms of thyroid. One is thyroid storm and the other one is the myxedema coma. Thyroid storm, where there is abrupt increase in your T3 and as well as T4. So thereby what will be the manifestations? They'll have very severe tachycardia and arrhythmia, marked delirium, vomiting, diarrhea, severe dehydration, and there will be high grade fever. Okay, and in these patients with hyperthyroid storm, what would be the cause of death? The cause of death would be high output heart failure, right? High output heart failure. That will be the cause of death in these patients with thyroid storm. And these patients, the mortality is very high in case of this thyroid storm, right? Then how do you manage these patients with thyroid storm? The drug of choice will be nasogastric propyl thiouracil. That will be the drug of choice. Okay, that will be the drug of choice, right? And this nasogastric propyl thiouracil, this will prevent the conversion of T4 to T3. And the other treatment options in thyroid storm is the application of ice packs, sodium bicarbonate because they will develop acidosis, IV propranolol should be given because they'll have very severe tachycardia, and Lugol's iodine should be given because it's a thyroid constipating drug. So this will be the treatment options for thyroid storm. Then myxedema coma. Like what exactly happens in myxedema coma? It is the abrupt increase in the thyroid hormone. Okay, abrupt and severe decrease in thyroid hormone. That is what is called the myxedema coma. And what will be the manifestations in myxedema coma? They'll have severe hypothermia, they will have hypoglycemia, they will have hyponatremia, hypoventilation, and all other features of hypothyroidism will be there in severe forms. And these patients, they can have the dilutional hyponatremia, and that makes the individual to develop into a state of coma. And there are certain precipitating factors for the development of myxedema coma, like sepsis, then exposure to cold, hypoglycemia. These are the precipitating factors for myxedema coma. So in these patients, the drug of choice will be intravenous T3, that should be supplemented in case of the myxedema coma. And all apart from that, whenever there is hypoglycemia, you need to give intravenous dextrose, and all other treatment, supportive treatment should be given. Okay, then coming to the investigations in patients with the thyroid, that is radioactive iodine uptake studies. So which particular radioactive iodine we use is the iodine 131. Remember, your iodine 123 or iodine 132. I'm very sorry. So which particular radioactive iodine we use for radioactive iodine uptake studies is iodine 123 or iodine 132. And where do we use this iodine 131? This iodine 131, it is used for therapeutic purpose. And you should know all the conditions where there is high radioactive iodine uptake and all the conditions where you will have low radioactive iodine uptake, out of which Graves is very, very important. And in low radioactive iodine uptake, decurvains is very, very important condition that you need to know. Now let us discuss the treatment in patients with the thyroid abnormality. Okay, so pregnant women is diagnosed of suffering with the Graves disease. The most appropriate therapy for her would be, right now, yes. So if you see this question, pregnant women, what is the antithyroid drug that you need to give? That is propyl thiouracil. So in the first trimester, we need to give propyl thiouracil, whereas in second and as well as third trimester, the drug of choice will be the methimazole. Now, why is that we don't give methimazole in the first trimester? Because methimazole, it is teratogenic drug, right? Methimazole is teratogenic drug. It can cause aplasia cutis. So that is the reason why we don't give methimazole in the first trimester where there is organogenesis. Whereas drug of choice in non-pregnant individual, that will be the methimazole. Okay, right. Then followed by that, the hypothyroidism. So treatment for hypothyroidism. 40-year-old female who is known case of ischemic heart disease is diagnosed as having hypothyroidism. Which of the following would be the most appropriate line of management for this patient? See, the patient is having ischemic heart disease. So, an individual with an underlying ischemic heart disease with hypothyroidism, you should not start full dose of thyroxine. You should start low dose of thyroxine. Actually, what is the dose? 1.6 micrograms per kg body weight. That is the dosage of thyroxine, which is nothing but your T4. But whereas in patients with ischemic heart disease, you need to start with low dose. If you give high dose, the underlying ischemic heart disease can get precipitated. So that is about your story related to thyroid abnormalities. Okay, so we are done with the thyroid, hypothyroidism and as well as hyperthyroidism. Then coming to the diabetes mellitus, right? 10 minutes we'll discuss the diabetes mellitus. We will be almost done with the endocrinology, right? So you see this question, very, very important clinical scenario. 47-year-old woman complaining of weight loss. She has the family history of type 1 and type 2 diabetes mellitus, but has never been diagnosed herself despite finding of islet cell antibodies. 47-year women having islet cell antibodies. In the last few months, however, she has noticed progressive increasing polyuria, polydipsia, and 5 kg weight loss. Fasting glucose 8 millimoles. That means 8 into your 18. So that is more than 100. Fasting is more than 100. And urine dipstick shows the presence of ketones. What do you think is the most likely diagnosis in this clinical scenario? It is LADA, latent autoimmune diabetes of adult. So what exactly is LADA? It is the one which is seen in adults. Latent autoimmune diabetes of adults. And in these patients, you have autoimmune antibodies. 47-year women, right? Until certain point of time, there is no diabetes. But after few days, after 47 years of age, you are noticing that there is hyperglycemia and antibodies are also there. So what do you think is it suggestive of? This is suggestive of the LADA, that is latent autoimmune diabetes of adults. Okay. And in latent autoimmune diabetes of adults, what are the antibodies? That is anti-GAD antibodies. So thereby, what will happen to the insulin levels? Decreased, because that will cause beta cell destruction. So what do you think is the treatment for your LADA? The treatment for LADA will be insulin. The treatment for LADA will be insulin. Then what are the all other forms of diabetes mellitus? Okay, these are all the other forms of diabetes mellitus. Type 1 diabetes mellitus, type 2 diabetes mellitus, other types, and as well as gestational diabetes mellitus. So type 1 is what? It's an autoimmune condition. You have, what are the antibodies? The antibodies are the anti-GAD antibodies. Then you have islet cell antibodies. So they will cause beta cell destruction, causing the insulin deficiency. And type 2 diabetes mellitus, the insulin resistance, that is a pathogenesis. Why is that insulin resistance? That is because of the chemical mediator, that is resistin, which is being released. And there will be increased insulin in case of type 2 diabetes mellitus. And what are the other types? That is MODY and as well as LADA. That is the other form of diabetes mellitus. Maturity onset diabetes of him, and LADA just now we have discussed. And gestational diabetes mellitus is the one which is seen in pregnancy. Now, if you see this question, I'll discuss about the MODY and all. So which of the following endocrine disorder does not lead to diabetes mellitus? Pheochromocytoma, somatostatinoma, hypothyroidism, acromegaly. Now, anyone of you quickly? Yeah, Rakesh. Treatment for hyperthyroidism, drug of choice will be methimazole in non-pregnant individual. But whereas in pregnant female in first trimester, it is propylthiouracil. Whereas second and third trimester, it is methimazole. Okay, right. So the one which will not cause the diabetes mellitus is your hypothyroidism. In hypothyroidism, the glucose levels, they remain normal. Only in case of myxedema coma, they may go into a state of the hypoglycemia. Whereas remaining all, pheochromocytoma will increase the blood glucose levels. Somatostatinoma will increase the blood glucose levels. Acromegaly will also cause increase in blood glucose levels. And the other endocrine disorders apart from these, other endocrine disorder that can cause hyperglycemia is hyperthyroidism. Right? And then Cushing's. And then Cushing's. So these are the endocrine disorders that will lead to the diabetes mellitus. Now, let me discuss some of the important image-based questions in the diabetes mellitus particularly. So, what is the use of this particular instrument and what is this instrument, right? So, what exactly this instrument is? It is a monofilament test, right? And it is a two-site semi-Weinstein monofilament test, right? It is the two-site semi-Weinstein monofilament test. And this is the test which is being done mainly to test the peripheral neuropathy. Loss of sensation, is it there or not? That is what is this particular semi-Weinstein monofilament test is being used for. Then, next you see the, right, what is this sign and in which clinical condition do you see this? So this is the one which is asked many times in the previous year questions, right? This is called prayer sign. This is called prayer sign. And we call it as the diabetic chiropathy. We call it as diabetic chiropathy. So these patients, when the blood glucose levels are very high, right, they will have difficulty in approximating both the arms together. When the blood glucose level return back to normal, then they will be able to approximate both the hands. That is what is called the prayer sign, okay, which is called diabetic chiropathy. Now, one more important endocrine abnormality in the diabetes is xanthal asthma. What is that? In patients with type 2 diabetes mellitus, they are at increased risk of dyslipidemia, type 2 diabetics. So these dyslipidemia, or whenever these lipids, when they accumulate in the clusters, then it can cause this xanthal asthma. And another important image-based question in your diabetes is the development of the ulcer. It's a neuropathic foot ulcer. Why? It is not an ischemic ulcer. Why? Because it is present over the sole of the foot. And how are the edges? The edges are very clean. And what is the treatment? Hyperbaric oxygen therapy, right? And one more cutaneous manifestation that you will see in diabetes is necrobiosis lipoidica diabetica. This is most commonly seen in the lower limbs, most commonly seen in the women. And how will be the appearance of it? It is a shiny red-brown patches. Okay. Then the another important skin manifestation in diabetes mellitus is acanthosis nigricans, where you have a hyperpigmented skin over the nape of the neck or within the armpit. That will be the that is a cutaneous manifestation in diabetes mellitus. Now, if you take the risk factor for diabetes mellitus, type 2 diabetes mellitus correlate with which fat reserve? Intra-abdominal fat, lower body fat, subcutaneous or upper body fat. Remember, it is the central obesity which is a very, very important risk factor for the development of the type 2 diabetes mellitus. Central obesity. And you have many other risk factors for causing type 2 diabetes mellitus, like vitamin D deficiency, right? Family history, very, very important. Smoking, sedentary lifestyle, consumption of excessive fatty diet. These are all the risk factors for the development of type 2 diabetes. Okay, right. And the next important, yes, this is a very, very important condition. A 29-year-old male taking oral hypoglycemic drugs, never had ketonuria in his life, BMI is 20.5, grandfather had diabetes, father, who is the only son of his grandfather, too had the disease. Which type of diabetes is this particular person most likely suffering from? Pancreatic, MODY, type 1, then type 2. What exactly do you think is the diagnosis in this condition? Right. So in this, it is MODY, that is maturity onset diabetes of young. Maturity onset diabetes of young is the one which is seen in the age group of 20 to 30 years. And in these individuals, the BMI will be absolutely normal, right? And they never developed diabetic ketoacidosis. And they will have very strong family history. 2 generations, father and grandfather, both are diabetic, right? And the pathogenesis is beta cell dysfunction. And why is that due to? That is due to gene mutation, right? That is due to gene mutation. And this MODY, we have the common forms, that is 1 to 6, out of which your MODY 3 is the most common form. And in this MODY 3, the gene which is being mutated is the HNF1 alpha, right? That is a gene which is being mutated. Now, what will be the drug of choice in patients with MODY? That will be low dose sulfonylurea. That is what you will give in patients with maturity onset diabetes of young. Okay, so we are done with MODY, we are done with LADA. Okay, and we have done with type 1 and as well as type 2 diabetes mellitus. Then how do you investigate these patients with the diabetes mellitus? Okay, so normal value of fasting blood glucose less than 100, postprandial less than 140, HbA1c normal value less than 5.6, impaired value of fasting will be 101 to 125, whereas ppbs it is 141 to 199, whereas HbA1c that is 5.7 to 6.4. Whereas in diabetes mellitus, if you take, fasting should be more than or equal to 126, postprandial should be more than or equal to 200, and HbA1c should be more than or equal to 6.5. Okay. Then the next important investigation is the random blood sugar. Random blood sugar, if it is more than 200, along with that, if there is clinical features of diabetes mellitus, then also we consider it as diabetes. And what is a gold standard test? The gold standard test will be the OGTT, that is the oral glucose tolerance test. Okay, right. So that is about the investigations that you come across in patients with the diabetes mellitus. Now, what is that particular parameter that tells you about the microvascular complications in diabetes mellitus? HbA1c. More is your HbA1c, more is the risk of development of microvascular complications. And you need to know three important phenomenon in diabetes mellitus. Okay, you see here. Early morning hyperglycemia with increased blood glucose of 3 a.m. suggest. The options are the insufficient insulin, dawn phenomenon, Somogi effect, and then none of the above. So what do you think is the correct answer here? No, no, no. It is not Somogi effect. It is not Somogi effect. It is not Dawn's phenomenon. It is insufficient insulin. It is insufficient insulin. Okay, right. Now let me explain to you all these three scenarios. So now you see what are the causes of early morning hyperglycemia in patients using insulin. Causes of early morning hyperglycemia in patients using insulin. One is fasting hyperglycemia, dawn phenomenon, Somogi effect. What is the mechanism? You take fasting hyperglycemia. Fasting hyperglycemia in these patients, what will happen is these patients, they are taking lesser dose of insulin. Right? These patients, they are taking lesser dose of insulin. 20 units is prescribed, but instead of 20, the patient is taking only 10. So thereby what will happen? Throughout the night, so you take 3 a.m. blood glucose will be high, 6 a.m. blood glucose levels also will be high. So what is the treatment? You increase the dose of insulin. That is fasting hyperglycemia. Dawn phenomenon, right? Why does this particular dawn phenomenon occurs? In diabetic patients, right, there is early morning growth hormone surge. Right, there is early morning growth hormone surge in diabetic patients taking insulin. Okay, so growth hormone, what it will do to blood glucose level? It increases. So 3 a.m. blood glucose levels will be normal, but 6 a.m. blood glucose levels will be high. That is because of growth hormones, right? So treatment is these patients should avoid taking any carbohydrate diet late in the night. Somogi phenomenon. Why is this Somogi? That is because of increased insulin administration. The patient is advised 10 units, but by mistake patient has taken 20 units. So what happens? Whenever the patient has taken insulin excessively, 3 a.m. blood glucose level will be reduced. When 3 a.m. blood glucose level is reduced, there will be release of counter-regulatory hormones, glucagon, steroids, catecholamine, thyroid hormone. All these, they will increase the blood glucose levels, growth hormone. They will increase the blood glucose levels. So 6 a.m. blood glucose levels will be high. So what is the treatment? You need to decrease the dosage of the insulin. So this is what is your Somogi effect, which is also called rebound phenomenon. Now, if you go back to the question, what is given in our question? Early morning hyperglycemia with increasing blood glucose at 3 a.m. That means 3 a.m. blood glucose is also high, 6 a.m. blood glucose is also high. What is that? It's an insufficient insulin. Okay. So this table is very, very important. So as I have said you earlier also, immediately after the class, the PDF with annotations will be sent to the Telegram channel, either Dr. Bhanu Prakash Telegram channel and as well as my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Guba. I will send it to you. Right now, in obese, non-insulin dependent diabetes mellitus, that means what? Type 2 diabetes mellitus, presents with fasting 180, postprandial 260. What does the management include? So now what exactly is the drug of choice here? Because this is in a diabetic range. So diabetic range, always remember the first line treatment in type 2 diabetes mellitus will be lifestyle modification. That is diet and exercise. Along with that, the drug of choice will be the metformin. Drug of choice will be metformin. Okay. So the first line treatment, lifestyle modification. Drug of choice, metformin, because it will cause maximum reduction in the HbA1c. How much HbA1c it can reduce? It can reduce the HbA1c by almost 2%. That is the reason why it is considered as drug of choice. Now, if you see the complications in diabetic ketoacidosis, most useful investigation in the diagnosis of DKA. See, DKA is that which is characterized by a triad. What is a triad? In case of diabetic ketoacidosis, glucose levels will be more than 250, ketone bodies will be positive, then the pH will be the acidic pH. But the most useful investigation will be ketonemia. It is not urinary ketone. Why? Because if you take the ketone bodies, you have acetone, acetoacetate, and then beta hydroxybutyrate. This beta hydroxybutyrate does not appear in the urine. So that is the reason why the ideal investigation will be the ketonemia. It is not the urine ketone bodies. Now, in the patients with diabetic ketoacidosis, what do you think is the treatment of choice? So, right, this is the triad. Now, these patients, they'll develop metabolic acidosis, that is high anion gap metabolic acidosis. What will be the presentation in patients with diabetic ketoacidosis? They will present with dyspnea, they'll present with abdominal pain, they'll present with profuse vomiting, they'll present with severe dehydration. That is what is the presentation in diabetic ketoacidosis. And they'll have a characteristic respiratory pattern that is called Kussmaul's respiration, where the respiratory rate is increased and even depth of respiration is also increased. So increase in rate and as well as depth of respiration, that is called Kussmaul respiration. Then what is the first line treatment in diabetic ketoacidosis? That is IV fluids, normal saline should be given, and followed by that you give IV infusion of the insulin. IV infusion of the insulin. That is, we mainly give the regular insulin. Then another important acute complication in the diabetes is hyperosmolar non-ketotic coma. This is more common in type 2 diabetics rather than type 1 diabetics. Okay, and these patients, they'll have the CNS manifestations in the form of altered sensorium and as well as seizures. And in these patients, the serum osmolality will be very high. Why is that serum osmolality very high? Because the glucose level in these patients are in a range of 600 to 1200 milligrams per deciliter. That is the reason why the serum osmolality is increased, but ketone bodies will be absent. And what will be the first line treatment in these patients also? That will be the IV fluids. That will be IV fluids. Okay, right. Yes, Ravi Kiran. So it is like initially we give bolus. How much of bolus we give? Insulin, we give 10 units bolus. Followed by that, we continue infusion. And that infusion will be at a rate of 0.1 unit per kg body weight. That will be the infusion rate. Okay. Only thing that you should be monitoring whenever you are giving insulin infusion is potassium. When potassium level reduces less than 5, you should give KCl supplementation. Okay. Right. Then you take the chronic complications. So you see this question: a 55-year-old diabetic woman presents with altered sensations in her hands and feet. She finds it difficult to turn pages of books and discriminating between the different coins. While walking, floor feels different, and she likens the sensation of walking on a cotton wool. The most likely diagnosis is autonomic neuropathy, diabetic amyotrophy, acute painful neuropathy, distal symmetrical sensory neuropathy, diabetic amyotrophy. Right. Now, if you see this particular question, the answer is the symmetrical sensory neuropathy, because you see in the both the hands and as well as both the feet, the individual is having the sensation of paresthesia, altered sensation, walking like on a cotton wool. These are nothing but your paresthesias and dysesthesias. So this is suggestive of distal symmetrical sensory neuropathy. That is the most common form of neuropathy in the diabetic patient. Right, most common form of neuropathy in diabetic patient. Okay, right. Now, what are the chronic complications that you come across? If you take diabetic neuropathy, in diabetic neuropathy, the sensation which is being lost first will be sensory sensations. So if you take sensory, motor and autonomic, the first which is being lost is sensory, and that too within the sensory, it is the vibration which is being lost. And if you take the cranial nerve which is being lost first, that will be the third cranial nerve, followed by that the seventh cranial nerve. But what is the importance of third cranial nerve involvement in diabetics here? It is, in spite of third cranial nerve involvement, the pupil will be of normal in size. Normally, when third cranial nerve palsy is there, there should be mydriasis. But here, the pupil will be normal. Okay? Right. And you see the another clinical scenario. Patient presents with symptoms of hypoglycemia. Investigation revealed decreased blood glucose and increased insulin level. C-peptide is done, which shows normal C-peptide levels. So what do you think is the most likely diagnosis? This is one of the PYQ. Right? Insulinoma, accidental sulfonylurea ingestion, accidental exogenous insulin administration, accidental metformin ingestion. So what exactly is the answer here? That is accidental exogenous insulin administration. Why not insulinoma, or why not your sulfonylurea ingestion? Because the C-peptide levels in both of these conditions increases. Insulinoma, insulin is produced. Along with insulin, C-peptide is also increased. Sulfonylurea, what do they do? They are the insulin secretagogues. And this sulfonylureas, along with insulin, the C-peptide levels are also elevated. But here, the C-peptide levels are normal. So, exogenously administered insulin, they doesn't contain the C-peptide. So, that is the reason why the insulin level will be high. C-peptide level will be normal, causing hypoglycemia. That is your exogenous insulin administration. Okay, right. Then the next, okay, so that was completely about your diabetes mellitus. We are done and dusted with the diabetes mellitus. Next thing is about the the MEN syndromes, that is multiple endocrine neoplasia. So we have four types: MEN 1, MEN 2, MEN 3 and as well as MEN 4. You take MEN 1, you need to remember 3 P's, right? That is, it is Wermer syndrome, right? It is Wermer syndrome. 3 P's. What are 3 P's? pituitary, parathyroid, and as well as the pancreatic. Out of this, which is the most common P? The most common P will be the parathyroid tumor. Okay, and adrenal and thyroid will not be there commonly, and extra endocrine manifestations will be there, and that will be in the form of carcinoids. And you take your MEN2A, which is also called Sickle syndrome. And in case of MEN1, the gene which is being mutated is the MEN1 gene is being mutated. And what is the chromosome that is being abnormal? The chromosome that is being abnormal here is the chromosome 11. On chromosome 11, the MEN1, which is a tumor suppressor gene, that will be defective. Okay. Then you take MEN2A and as well as the MEN2B. In MEN2A, just remember this mnemonic, that is PAT. What is PAT? P stands for parathyroid abnormality, A stands for adrenal pheochromocytoma, T stands for thyroid, that is medullary carcinoma of thyroid. Okay. And in MEN2A, what are the extra endocrine manifestations? That will be Hirschsprung's disease will be there and amyloidosis will be there. That is MEN2A, which is also called Sickle syndrome. Then you take MEN2B, which is also called MEN3. And this MEN3, we call it as Wagenman-Frobois syndrome, right? And what is the mnemonic in MEN2B, which is also called MEN3? You have only at, P will not be there, right? P will not be there. Adrenal pheochromocytoma will be there and medullary carcinoma of thyroid will be there. Then what are the extra endocrine manifestations? Extra endocrine manifestations will be the marfanoid habitus and there will be neuromas, right? And the gene which is being mutated is RET proto-oncogene, and this RET proto-oncogene is present on the chromosome 10. Okay, so that is about your MEN2A and as well as MEN2B, which is also called MEN3. Then what is about MEN4? MEN4, the gene which is being mutated is CDKN1B, right? CDKN1B. And in these patients, you have reproductive organ tumors. That is, in males, you will have testicular tumors, whereas in females, there will be the cervical tumors. So that is what is your MEN4, right? Then followed, yeah. So next important question is, Werner syndrome is associated with. This is one of the PYQ. MEN1, MEN2A, MEN2B, and none. So the answer here is, it is not MEN1, it is none. Because what has been given here is Werner's. What is MEN1? MEN1 will be Wermer's, right? Now, if you take this Werner's, what exactly is this? This is progeria, which is nothing but premature aging, right? Which is nothing but premature aging. So this is about your MEN syndromes, right? And the last two topics will be carcinoid syndrome and as well as the glucagonoma, right? Now you take this carcinoid. What exactly is this carcinoid? It is a neuroendocrine tumor where there is excessive production of the 5-hydroxytryptamine, that is serotonin. And this carcinoid syndrome, like, it is coming from that neuroendocrine tumors, and that we call it as the carcinoid tumors. That we call it as the carcinoid tumors. So we have the typical carcinoid and atypical carcinoid. What is the difference between these two? In typical carcinoid, along with increase in plasma serotonin, there will be increase in your urinary 5-hydroxy-indolactic acid and argentafin will be positive. Whereas atypical carcinoid, the plasma serotonin levels will be normal, but your 5-hydroxytryptamine level will be increased and argentafin will be negative because serotonin levels are normal. That is what is the difference between typical and as well as the atypical carcinoid. Okay. Then in the carcinoid, you also have the individual systems which are affected. That is carcinoid heart, where the right side of the heart will be affected. And the manifestations, please remember, that is TIPS. What is TIPS? Tricuspid insufficiency, pulmonary stenosis. That is what is your carcinoid heart, where right-sided valvular defect will be there. Then what will be the gastrointestinal manifestations in carcinoid? That will be in the form of the diarrhea. Then what will be the respiratory manifestations? There will be bronchoconstriction. There will be asthma or dyspnea will be there in patients with the carcinoid syndrome. Okay. Then how will you diagnose? So see, typical carcinoid, you need to check 5-hydroxy-indolactic acid. Whereas atypical carcinoid, the 5-hydroxy-indolactic acid, that is serotonin, will be normal. In these patients, 5-hydroxytryptamine levels will be elevated. That is how you will diagnose the typical and as well as atypical carcinoid. Then how is that you will do imaging? I mean, how will you localize the tumor? The localization of the tumor is by the octreoscan, right? For localization of both primary and as well as metastatic lesion, you need to do the octreoscan. And the scan which is more sensitive will be gallium-68 label dotatate scan. So gallium-68 dotatate octreotide scan, that is most sensitive or superior to conventional octreoscan. Okay, then what will be the treatment in these individuals? For symptomatic relief, we need to give somatostatin analog, that is octreotide. The alternative drug will be telotristat ethyl. This will be for symptomatic relief of carcinoid syndrome. Okay, so this is about your carcinoid, right? Yeah, Meghavi. What is paraganglioma? See, what is paraganglioma is, paraganglioma, we come across this in pheochromocytoma. That is extraadrenal pheochromocytoma is nothing but your paraganglioma. Alright? Next. So this was about your carcinoid. And the last topic in endocrinology is the glucagonoma. Glucagonoma is the recently PYQ, right? This particular glucagonoma was asked in the recent INI-CT exam. Okay, so glucagonoma, it's a tumor which is originating from the alpha cells of the pancreas, where there is excessive glucagon production. What will be the features in these patients? They will have necrolytic migratory erythema. It's a malignant condition, so you will have weight loss, and there will be mild diabetes mellitus that you will have in these patients with the glucagonoma. And this glucagonoma, it forms the part of the MEN1, because in MEN1 you have the pancreatic tumors. What are all the pancreatic tumors? The pancreatic tumors include the most common pancreatic tumor in MEN1, that will be pepoma, right? That will be pepoma. That is the most common pancreatic tumor in MEN1. Okay, that is pancreatic polypeptide will be produced in excess quantity. Then what are the other tumors, pancreatic tumors? Somatostatinoma, insulinoma, glucagonoma. These are all your tumors of the MEN1, right? And how will you diagnose glucagonoma? Diagnosis of glucagonoma is by estimating the glucagon concentration, and if the levels are more than 500 milligrams per ml, that is suggestive of the glucagonoma. Then how do you treat these patients? The same drug like what we give for carcinoid, that is octreotide, which is a somatostatin analog. What is the mechanism of action of this drug? That will inhibit the release of the glucagon. And what are the alternative drugs? That is the doxorubicin and as well as streptozotocin have also been used successfully to selectively damage the alpha cells of the pancreatic cell. So this is about your the glucagonoma. So this, with this we are done with all the topics of the endocrinology, right? So what is that, all the topics of endocrinology you see here? This is the list of topics which we have completely revised now, including image based questions and as well as previous year questions. So this is about your endocrinology.